Welcome back to Day 4 of our International LGMD Conference. Thank you to our platinum sponsors of the conference, Sarepta Therapeutics, AskBio, and GFB Onlus. We're excited to hear from presenters from all around the world today. Limb-Girdle muscular dystrophies are equal opportunity diseases. They occur in all parts of the world among people of all racial backgrounds. In this session, we're highlighting some of the initiatives happening around the world. We're delighted to have 3 clinicians based in India, Egypt, and Chile who are playing leading roles in furthering diagnosis, clinical studies, and advocacy for LGMDs in their respective regions. To introduce our panelists is Sarah Emmons of the Jain Foundation. Welcome, Sarah.
Thanks, Brad. My name is Sarah Emmons, and I direct the global outreach and community strategies at the Jain Foundation, which is focused on one subtype known as Dysperalenopathy, or LGMD 2B, R2, and Miyoshi Myopathy type 1. It is with great pleasure that I introduce Session 8, which brings together global updates from India, Egypt, and Latin America. Each speaker brings decades of experience to their presentation and has demonstrated relentless passion while helping to promote progress in the field of LGMD clinical care and research. It's my pleasure to introduce 3 speakers who've made great contributions to LGMD advocacy and with whom I've had the privilege of collaboration on various initiatives over the years. Today, each of these exceptional speakers will share updates from their part of the world and speak about what patients from India, Egypt, and Latin America might want to be aware of. Because LGMD occurs worldwide, efforts in diagnosis, advocacy, and clinical studies need to be developed worldwide, and these speakers have made major contributions in those areas. First, we have Dr. Jorge Bevilacqua, who has an MD and a PhD and practices medicine in Santiago, Chile, and has a long dedicated history of involvement behind the scenes teaching, facilitating clinical meetings, providing access to diagnostics, collaborating on research studies, and fostering a strong LGMD patient community at his clinic. Recently, Dr. Bevilacqua has become a principal investigator for the natural history study that the Jain Foundation is conducting for Dysperalenopathy. He also demonstrates care for patient education, having authored personal messages to patients for global distribution. Through this messaging, he teaches the community how to identify quality research articles aimed at helping patients discern between a quality article and a sensational write-up in the media. Please welcome Dr. Bevilacqua.
Well, thank you, Sarah, for this introduction and the invitation to give this conference. I will give some thoughts on the neuromuscular disorders in Latin America from my own point of view. This is by no means scientific information, is only my point of view of some issues of the state of the art of neuromuscular disorders in Latin America. So for making an introduction, Latin America is about the 8% of the world population, and most of the people live in urban in cities, and we are together about 660 million people, from which a third are Brazilians and 20% are Mexicans. There are main 2 languages, Spanish and Portuguese, which sometimes is a trouble of communication, and is a very extremely contrasting continent with mainly underdeveloped places with some pockets of development, which is equivalent to the first world. There is a great geographical and biological diversity, and the genetic of the population is continuously evolving because of migration, and is also part of the problem in neuromuscular diseases. In this review, the colleagues from Argentina make a statement on some issues on the management and the neuromuscular diseases and spinal muscular atrophy in Latin America, emphasizing that there is a marked political and cultural and economic differences, including different law regimes, which impede in sometimes healthcare and scientific and research, as well as treatment. In general terms, there is a lack of access to specialized medical centers, or those specialized clinics are only in big cities and in one or two centers in very large countries. In those terms, it's very heterogeneous, the medical and the scientific development in different parts of the continent, with a very poor epidemiological knowledge for most of the neuromuscular disorders. So it's difficult to talk about the whole continent because there are many different countries and many different situations, but in general terms, in my experience, there is a problem of a vicious circle of rarity, what I call, which is because neuromuscular disorders are rare, they attract very little attention, and because they don't have any attention, medical schools and scientific programs don't spend much effort on them. And because of that, we don't have data, we don't have epidemiological data, and rare diseases will become again rare because nobody knows about them. Other factors that are discouraging care is that obviously there are more frequent and important priorities. As I said, there is a very little attention on medical schools, and sometimes the institutions for education are obsolete and do not allow to create new disciplines, for example, translational myology. And as you well know, there is a high cost for diagnosis, for treatment, and there is quite a frustrating situation for most of the medical community. Finally, the high cost of the novel therapies, extremely high cost, and the judicialization of the problem is another difficulty that the medical community is trying to get away from. Some initiatives, however, are starting to appear from the official government offices and ministries, but still is a very incomplete effort. Concerning the access to diagnostic testing, I use the same slide I show you in another presentation, in another session, session 7. As you can see in green, the things that are mostly present all over the continent, with some warnings in cases like, for example, the antibody testing. And when you get to muscle imaging, muscle biopsy, molecular genetics, only few countries at all are able or capable to doing good performing testing. As I said, this is quite variable in different parts of the regions, and in most places, we don't have no much access to anything. For example, in Chile, only this kind of methodology is only available in private clinics, so the government does not cover the costs of any of those studies. In other countries, there is a mixed between public and private health networks that cover the costs for those methods. In general, there is a lack of the vision from the governments of the problem as a whole, and there are some individual efforts to sort out some of those problems. There is very little transnational networking in the region, and most of the success of some initiatives are based on individual scientific or patients associations initiatives, but not from a global policy from governments in general. So this is a very long table of the conditions, the availability, comment, and possible solutions. But in general terms, we can resume that what we require is much more education, specialists very well trained to diagnosis, to treat, and to care for those types of patients. And the need of networking is quite important. We still don't reach to a level which would be acceptable to treat properly the patients. With regard to management and treatment, Again, the lack of specialties and people qualified to do good management of the physiotherapy of neuromuscular disorders is a common problem all over. There are many initiatives, in particular, the Teleton initiative that is, associated in a networking of teletons, but teleton is present in most or many countries in the region, but some other countries don't have any access to this. Also, the centers of rehabilitation are limited many times to children and teenagers under the 20 years old, and adults are not or much less covered. And obviously, there is a very, very difficult access to novel, extremely expensive therapies. Just to try to be part of the solution, some quick, good examples. For example, that's my own experience. In Chile, by the year 2000, Dysperalenopathy was not known to exist in the country. So we explored the first case in 2003 and a second one in 2005. And by 2006, with the help of the colleagues from Marseille, France, we were able to confirm that it was Dysperalenopathy. Because of that, it was the first time in a laboratory of a pathology in the country, the only one existing, was an immunohistochemistry staining for dysferlin made. Following, a few years later, we were successful to have a research grant on the field and see how the number of people having the disease appear to rise up in the country, indicating that the people was always there, but we didn't have access to this because nobody paid attention to them. So once we discovered that the problem was existing, things started to move, and then we established some characteristics of the genetic problem in the country, and following, actually, we have at least 5 pathology labs capable of doing dysferlin diagnosis, and at least 4 imaging centers capable to perform MRI and muscle that developed starting in our effort to try to promote the diagnosis and the study of those patients. So again, the current possibilities for quick and cheap genetic testing are becoming much accessible. And as I explained in another presentation, nowadays, there is no need in many cases for many invasive and complicated and expensive diagnostic tests. Some global initiatives and projects are promoting quick genetic testing for free or a very low cost for patients. And in this way, about half of the patients will reach a definite diagnosis without much cost and effort, with all the consequences that they are beneficial for them. In those lines, for example, currently, we are having this DETECT program, which is in association with Invitae and the pharmaceutical industry and patients associations in some countries of the region and others in the world, in which most of the Limb-Girdle muscular dystrophies and many other myopathies can be quickly diagnosed at no cost for the patient. This is a very, very important initiative, and you need to be aware of that, to ask your physicians, your medical team, to be informed and to use these facilities. Another example was a program launched by Sanofi Genzyme, in which in Latin America, we were able to study 2,000 patients. And the project is still going on with a small panel of genes that allow to the diagnosis of many patients who didn't have access to any form of diagnosis if it was not because of this program. these type of initiatives are very important and are helping to unravel the knowledge on the field across the world and in Latin America also. So what can we do as a patient to be part of the solution? Well, it's very important for the medical community to be collaborative with research projects, to be informed and to demand the diagnosis and the things you are informed to be going on the field, because sometimes in some part of Latin America, the medical community is not pretty well informed. So another important, very important point is to enroll on the registries. That's the only way that to make yourself known and having your illness, and eventually you will be able to access to trials and treatment later on. But if your disease and yourself is not known to the medical and scientific community, and nobody knows what disease do you have, it is impossible to reach any benefits of the things are happening to help the patients. Again, associate with your other patients with your disease, associate with other patients associations in your country, and finally between countries and globally, because this kind of lobbying is very different and complementary to scientific and medical efforts to develop the knowledge and the management of this kind of health problems. Somehow, the pandemic showed us that it's not very difficult to be together, to connect, and that was a positive thing we have from the pandemic. And nowadays, it's very easy to do even a congress like this one online without the need of moving or traveling, which is quite expensive. Some take-home messages in general, but I don't intend to be exhaustive on this. I will say that it's important for you as a patient to always prompt for a definite diagnosis, to be inquisitive, but not confrontative with the health team, which is there to help you actually. It's important the patients to teach us about their problems and some details of the disease, that because there are rare ailments, it's impossible for the medical community to be aware of all the details. We are working together actually, and we need to learn from the patients. It's very important to organize yourselves, promote the knowledge of your disease, gather with other patients and other communities to, as I said, to do lobby and to promote the care for your condition and other conditions alike. And finally, be very wary and very careful of miraculous solutions that have been proposed. As an example, I put this issue of the Bondina, which is relevant in Latin America, stem cells of all the, because the saying that is too good to be true stands for this kind of initiatives. It's very important to be pretty well informed and be aware that if something is good for you, your physician and your medical team will be happy to inform or prescribe it to you, and there is no other intention in that attitude. So that's all I could tell you from my point of view. I'm sure there are many other issues that I didn't cover, but thank you.
Thank you, Dr. Bevilacqua, for your presentation. Next, you will meet Dr. Satish Khadilkar, an MD in Mumbai, India, where he has been an active facilitator of diagnostics to hundreds of LGMD patients in need of clarity on their LGMD subtype and how to best care for their bodies. Dr. Khadilkar has been personally involved and has had substantial communication with our organization and other patient communities. Please welcome Dr. Khadilkar.
Well, good morning, everyone. And it's a privilege and a pleasure for me to be here and to speak to you about limb-girdle muscular dystrophies in India. And this is a fantastic conference which has brought together the patients, the other healthcare workers, the pharmaceutical companies. And I think meetings like these are so important because they can get together people from various walks of the limb-girdle dystrophy, so to say, and do joint work. So the task given to me is to tell you a little about limb-girdle muscular dystrophies in India. Now, just to introduce the topic, I know you all know what limb-girdle muscular dystrophies are, but they constitute a large group of conditions which basically have weakness of the legs, weakness of the upper limbs, which very slowly progresses, and over a period of time, it produces disabilities of various kinds. Now, limb-girdle dystrophies are common in India. This is a general statement because India is a very large country and getting good epidemiological data is not easy. But every neuromuscular clinic sees these patients from time to time. So we do believe, those of us who work in India do believe that limb-girdle dystrophies are common in India. And the reasons are that ours is a very large country with genetic diversity of the population. If you look at the north, the west, the east, and the south, they're very different genetic backgrounds. And the conventional concepts of marriage are based on community. So often people will marry within the community. And therefore, I think even though there are so many of us in India, genetically speaking, it's little in genetic India is based on community marriages. So community marriage is a norm in India. And a little more than that, marriages of cousins or blood relatives, second degree blood relatives, are also traditionally practiced in some communities in India. So therefore, the genetic stock actually has been, so to say, isolated. And therefore, the autosomal recessive conditions are more common amongst those who practice the intracommunal exogamy, amongst those who practice the community marriages, among those who actually have cousin marriages. So we do see recessive limb-girdle dystrophies quite often in India. And in most of the clinics, history and clinical examination is the basis for making the diagnosis. And of late, I think the other facilities like muscle biopsy, the immunocytochemistry, the genetic advances have come to many large cities, and there's an ever-increasing possibility of getting your genetic workup done in reasonable cost within the country. So more and more knowledge is coming. So what do we know of LGMDs in India till now? Like I said, epidemiological data is basically hospital-based data from some centers that work in urban muscle. But I think it is very clear, in spite of the limited data, that calpainopathy and dysperalenopathy are the two most common limb-girdle muscular dystrophies seen all over the country. And depending on where you are, it may vary a little bit. Like if you're in South India, then you may see more of the autosomal recessive ones, which link with the sarcoglycan gene or the dystroglycan gene. So there are some regional variations. But all over, it is calpainopathy and dysperalenopathy. Now, early reports of the limb-girdle muscular dystrophy go way back to 1975, where people got together the patients that they were seeing. And these are the workers who did it early, Das in south of India, and Monkar and Baba from the west of India. So what do we know about LGMDs in India at present? We see dysperalenopathies, we see calpainopathies, we see sarcoglycanopathies. And you see a little spread of anoctaminopathy, dystroglycanopathy, myofibrillar myopathy, and then most others that have been documented in the world literature. Now, I have included Gne myopathy in this presentation, and the purist will say, oh, it's not a limb-girdle muscular dystrophy. Why have you included it? But very frankly, it is one of the common myopathies seen in India. And in many ways, it looks like a limb-girdle muscular dystrophy, even though it's a distal myopathy, largely, or to begin with. One does miss it for dysperalenopathy in particular. So I'm going to include a little bit of Gne myopathy. In fact, in the south of India, it is perhaps the most common myopathy that you see in the autosomal recessive group. So the Miyoshi myopathy, or the dysperalenopathies, as we know, can be distal or proximal. And that, I think, is important for everyone to recognize, that even though limb-girdle muscular dystrophy primarily talks about conditions that affect the hip girdle and the shoulder girdle, there is this variety, Miyoshi myopathy, which can start in the gastrocnemius muscle and look like a neuropathy or look like a SMA for the inexperienced observer. and then it sort of goes on to become proximal. And the LGMD2B, which is proximal. Now, most of us believe that dysperalinopathies as a group are proximodistal. And this difference between Miyoshi and LGMD2B is in a way arbitrary because one merges into the other. Now, I must make a mention of the Jain Foundation's work in Mumbai, India for dysperalinopathies. In 2009, they established the Southeast Asian Center for Dysferlin at Mumbai. Initially, we collected clinical data and immunological data and then plotted for some time, and then the genetic evaluation. And this was a team of people, Dr. Rashna Dastu, Dr. Pradnya Gaitonde. I was on the clinical side, and the Jain Foundation helped tremendously to set up this dysperalinopathy center. And very frankly, for a long time, they provided the genetic analysis free of cost, which in India is a tremendous advantage. And as a result of that work and some other projects that we went through, over 100 genetically confirmed cases were diagnosed in by 2015. And by 2021, I think it's about 350, but that's now not only with the JF. Now, we did not find any particular mutation to be common in dysperalinopathies in India. And there was no founder mutation that was detected on the 100 cases that were studied. So even though dysperalinopathy in India is common, the genetic defects are spread across various exons of the gene, and there is no particularly common defect, and there's no particularly common founder mutation. So that's about dysperalinopathies. Then we go to the calpainopathies. Now, they really stand, I think, from the available genetics shoulder to shoulder. I don't think one is commoner than the other. Now, calpainopathy is very peculiar in the sense that it produces an upper girdle involvement in many people. And actually, there is winging of scapulae. The shoulders do not work very well. And such patients look like facioscapulohumeral muscular dystrophy. So if you have a limb-girdle muscular dystrophy that is started in the upper limbs and there is scapular winging, then you think of calpainopathies. And these people toe walk. So upper girdle, scapular winging, toe walking, and weak abdominals are the clinical features of calpainopathies. And you cannot immunostain calpain, you have to blot it. You have to blot it at 3 frequencies, 94, 60, and 30 kilodalton. Now, the first papers for calpainopathy came from the north of India, All India Institute of Medical Sciences, where they blotted calpain and showed that almost 40% of patients of limb-girdle that they had collected, the calpain did not blot very well. And that was the first paper on calpainopathy from that center. Now, the advantage is that since you know that there is a founder mutation in this community, when a patient from this community comes with typical phenotype, we directly go for the founder mutation. We don't do any other test. And this was one study which we did, which showed that 90% of the times, only the founder mutation study was useful. Now, third is the Gne myopathy. And these are the two big people of Gne myopathy, Ikuya Nonaka and Zohar Argao. And this, in many ways, is a myopathy which is distal and proximal. It starts with the tibialis anterior and then goes on to the hip adductors and the hip flexors. And peculiarly, it spares the big front thigh muscle, the quadriceps. So these people have very strong quadriceps. And this is an MRI showing that you look, the vertical arrow shows you that the posterior part of the thigh is completely affected. And the horizontal arrow shows you that the front of the thigh, which is looking gray here, is completely normal. So really, for those who are experienced clinicians, it is not too difficult to pick up this myopathy. Actually, this particular gene came from the Roma, the Roma of Eastern Europe. This gene was known that the Romas have it. And we found it in Rajasthani people from India who had Gne myopathy. And for those of you who are interested, the Romas are believed to have originated in northwest of India. And then they have moved out of India and gone to various places to sort of populate various parts of the world. And this is one other genetic link that confirms that the Roma probably started 800 BC in Rajasthan. Then we'll make a little mention of sarcoglycanopathies. They look like Duchenne muscular dystrophies. They're young children, boys and girls with large calves, but you can also have milder phenotypes that go on to progress very slowly. And there is information on sarcoglycanopathies from all centers in India with various genes being detected, and the gamma sarc and the alpha sarc seem to be the commoner ones. And there are again 3 or 4 series available in Indian literature. So I think then, after having told you about these 4 common types of limb-girdle muscular dystrophies, let me make a statement that almost all the known genetic defects in world literature, there are patients who show those, and anaptomopathy and myofibrillar and most of the known limb-girdle muscular dystrophies have been documented from India, but they are few and far between. These are the 4 main groups: dystrophinopathy, calpainopathy, a little bit of sarcoglycanopathy, and Gne myopathy I'm including here, though it's strictly not a limb-girdle muscular dystrophy. Now, what's the other situation? The patient groups have started to form. There are patient groups of Duchenne muscular dystrophy, patient groups of Gne myopathy, patient groups of calpainopathy, and they are trying to come together so that they can exercise some influence on the way the research in these diseases goes. They can also talk to each other about the rehabilitation, talk to each other about the difficulties they had, and try and solve them. So these activities have actually started, and the revolution of communication, the WhatsApp and the Instagram and the Facebook, and so on and so forth, is really helping them to try and connect to each other. And in fact, I recently saw an example where there was an index case, and 3 family members were known because of the WhatsApp connections later on, that they had similar symptoms about which they didn't bother much, and it was a case of Gne myopathy. Having said that, the patient groups are still in very early time. The genetic nature of these diseases is a bit of a hindrance in forming a joining group, because some people don't want to declare that there is a condition that may run in the families for repercussions on the social aspects of the families. But more and more people are coming forward. More and more people are doing pre-marriage counseling. More and more people are doing antenatal testing. So I think the patient group movement is picking up. What still is lacking is the patient group and doctors and the government coordination for advocacy. I mean, there are patient groups in their own place. There are few doctors working in nerve and muscle disease in their own place. And the government really doesn't come to know what the issues are. And the representation to government is an area that really needs to be looked at. So, ladies and gentlemen, to summarize, the information on limb-girdle muscular dystrophies in the Indian context is slowly evolving. Dysperalenopathies, calpainopathies, GNEs, and sarcoglycans have been identified. I put sarcoglycan first because it was detected first, but it's not the commonest. Initially in immunostains, and then now with genetics. And large multicentric efforts have still not been put in place. But when they are, and I'm sure they will be, further information will come. The coordination between patient groups, medical personnel, researchers, and the policymakers is the next step to try and improve the patient care, research, and treatment projections for patients of limb-girdle muscular dystrophy in India. Ladies and gentlemen, thank you very much. And I must again thank the organizers for giving me this opportunity. Thank you very much.
Thank you, Dr. Kadalkar. Closing the session will be Dr. Rasha el Sherif, an MD, PhD from Cairo, Egypt. Dr. El Sherif has combined her clinical practice with research by publishing papers, serving on collaborative neuromuscular groups, and has established a nonprofit organization and patient registry. She does an excellent job keeping Egypt represented among global working groups as she collaborates with other doctors and researchers in Japan, Europe, and the USA. Please welcome Dr. Rasha el Sherif.
Thank you, Sarah, for such a kind introduction, and thank you very much for the conference committee for their kind invitation and the Limb-Girdle community to allow me to share the progress and challenges in our region. So the Limb-Girdle as a rare disorder represent a great challenge in most developing countries, including Egypt. The lack of awareness in the community in general and between patients interfere with early diagnosis and lack of proper health care. In addition, the socioeconomical burden on the family and the psychological burden on patients and families as the society may shame and seclude patients from incorporation in the community, especially in rural areas due to set beliefs, is a big issue in our region. The lack of resources, namely specialized medical professionals in neuromuscular disorders and specialized diagnostic and multidisciplinary care centers, represent an important obstacle in the region. Consanguineous marriage and high population represent an important issue regarding the autosomal recessive disorders as limb-girdle, In Egypt, the reported incidence of consanguineous marriage is on an average of 30%. And this is due to cultural aspects, especially in Upper Egypt, is accustomed to marry from the same family. There is a great positive changes happening regarding the Egyptian approach towards the limb-girdle muscle disease patients through the last years. When I started my training on the genetics of muscle disease in 1998, we were facing a lot of challenges. There was complete lack of awareness of the different types of muscular dystrophy. All patients came to the clinic diagnosed with no genetic testing or applying standards of care, which impacted the quality of life of many patients. The emergence of novel mutation-specific therapies in the world and the clinical trials gave a great hope for patients and medical professionals. The year 2012 was a turning point in Egypt, as the patient community understood the importance of patient organizations and working to teach out for patients. In 2012, the first specialized registry for limb-girdle was established, and it's called the Egyptian Neuromuscular Registry, and it's held by Myocare National Foundation. It became active in collaboration with TreatMD. And later in 2014, a group of limb-girdle R2 Disparinopathy patients established the first patient organization for muscular dystrophy. And in 2019, Myocare National Foundation received the official approval as the first professional NGO working for diagnosis and care of LGMD patients. Both organizations work to advocate for the rights of all patients for diagnosis, care, and access to novel therapies, and the developing clinical trials. The year 2021 we reached a milestone as muscular dystrophy became officially recognized as a national priority by the national authorities, and efforts of national program planned by Ministry of Health to include LGMD patients in the national insurance and to put a strategy for healthcare. So I'm going to start by introducing the Egyptian Neuromuscular Registry, which was established in 2012 in collaboration with TreatMD. And now it started as voluntary work, and now it's held by the Myocare National Foundation. Patient populations of rare disorders in general are often geographically scattered and struggle to find expert centers. And this relies on includes the muscular dystrophy and LGMD. So the vision of Myocare National Foundation was all people living with LGMD, no matter where they live, can reach a network of expertise to access appropriate diagnosis, care, treatment, and support. So Myocare was founded on three objectives: to create a network to reach out for all patients, share knowledge, resources, and technology, and prioritize the need of patients and families living with muscular dystrophy. Establish Muscular Dystrophy Center with trained medical professionals to allow access of affordable and highly specialized healthcare for diagnosis, care, and prevention of comorbidities. Promote research to identify the genetic and phenotypical characteristics of the Egyptian LGMD patients. The Egyptian Neuromuscular Registry was established in 2012 by voluntary efforts and in collaboration with TreatMD. And now it's hosted by Myocare National Foundation. This was the first NGO founded by a multidisciplinary team of medical professionals focusing on providing care for muscular dystrophy community. The Egyptian Neuromuscular Registry was established by voluntary efforts in 2012, and now it's hosted by Myocare National Foundation. It was established in collaboration with TreatMD. This was the first. Myocare National Foundation is the first NGO founded by a multidisciplinary team of medical professionals focusing on providing care for muscular dystrophy community. The registry welcomes patients from Egypt and all other neighboring countries. We use both Arabic and English languages. The registry holds more than 2,000 patients with genetically confirmed neuromuscular disorders, and currently there is 432 limb-girdle muscular dystrophy patients are registered since 2012. Since 2019, the approach to LGMD patients in Myocare and neurology departments in university of hospitals have changed and adopted the approach for diagnosing patients with LGMD starting with the clinical evaluation, laboratory tests, the CK, the neurophysiology, MRI muscle was included lately in 2019 in most of the neurology departments where muscle disease patients are seen. Muscle biopsy is done only in 2 centers, namely Myocare Foundation and Ain Shams University. Although the next generation sequencing until last year was then done by sending samples to collaborating universities, institutes, or commercial labs in other countries, although this is changing in the near future. Although the Egyptian Neuromuscular Registry is not a national registry, yet as it receives patients from all over Egypt, it can represent the prevalence of LGMD in Egypt. The registry holds around 432 patients, genetically confirmed LGMD patients from Egypt, although there is number of patients also registered from Libya, Sudan, Syria, Palestine, and Iraq. The highest percentage in our registry are from LGMD R2, the Dysperalenopathy, and then comes after it the calpainopathy, LGMD R1, then comes the sarcoglycanopathies and other types shown in the slide. One of the main efforts of the registry is patients' awareness. Our team traveled to many rural areas, cities, and villages, spreading the awareness about the importance of diagnosis and care for LGMD patients, and giving psychological support through educating patients and families. This is a photo of one of the sessions given by our psychologist, Dr. May, for parents and patients with LGMD. The other NGO is the Egyptian Muscular Dystrophy Patient Organization, which was established in 2014. This was the first and only patient organization in Egypt that is dedicated to help and support LGMD patients. Because of their efforts advocating in the Egyptian parliament for patient rights, now the Egyptian LGMD patients are included in the national health insurance. In 2021, the Egyptian authorities started huge steps towards rare disorders, including the LGMD patients. It became crucial to allow a national strategy for the future care of patients. 3 main projects are working in parallel to create future plan of care. The National Insurance Project, the National Muscular Dystrophy Project by the Ministry of Health, and the Egyptian Human Genome Project. Now LGMD patients are included in the national health insurance plans. The Egyptian Ministry of Health started a muscular dystrophy project as part of the initiative towards rare disorders in 2021, including the health insurance, specialized multidisciplinary clinics for diagnosis and management of muscular dystrophy patients in several cities in Egypt, referral centers equipped for genetic diagnosis of muscular dystrophy patients, and starting to train medical professionals in different cities, main cities in Egypt. And the future plan is the establishing premarital tests for autosomal recessive rare disorders with high prevalence among the Egyptian population and newborn screening. Challenges that we are facing in our region is primarily reaching out for patients. Patients need to be aware about the disease and importance of being diagnosed, importance of being included in the community. So patient access is one of the biggest challenges. Then train medical staff and qualified centers. I consider my patients and their families our heroes, leading very difficult life with lack of accessible communities. Schools are not designed or well equipped for patients with muscle disease. Patients diagnosed in early adulthood may need to quit their higher education and may limit their opportunities for jobs, which lead to economical and psychological burden. Our overall cultural consciousness on how we treat and interact with muscle disease needs to change, beginning in elementary schools, reaching to universities and workplaces. Still, many limb-girdle muscular dystrophy patients lack diagnosis and care. Due to limited resources, global collaboration with the WHO and Rare Disorder Organization will be very important in the future. Training medical professionals through inviting experts and incorporating with international muscle organizations like the TreatMD and WMS is crucial. Collaboration is very important in rare disorders, so regional networks for experts and patients in the region will allow dissemination of knowledge and more understanding of the nature of such disorders and needs of patients in the region, which may allow for future designed therapies for our population. At the end, I would like to thank my care team, the doctors who are behind all the efforts, traveling in convoys and giving awareness sessions, and our international collaboration with Dr. Nishino, the head of Department of Neuromuscular Research in National Institute of Neuroscience, and he is the scientific advisor for the Myocare National Foundation. Thank you very much.
We are excited today to present our next session, sponsored by GFB Onlus. GFB Onlus is a platinum sponsor and also a patient advocacy organization located in Italy and focused mainly on discovering treatments for LGMD 2E, also known as LGMD R4. Today, they have invited world-renowned speakers such as Dr. Yvonne Torrente, Dr. Doriana Sandona, and Dr. Carl Sanchez Riera. To start, Dr. Torrente will share his presentation.
Thank you, Carol, for your presentation. And I would like also to thank the organizing of this meeting, in particular also the people from the GFB, the group of families of patients affected by beta-sarcoglycanopathy. And I would like to share with you the results that we obtained about a clinical study related to the definition of some clinical determinants of disease progression in patients affected by beta-sarcoglycanopathy. The beta-sarcoglycanopathy are part of a large group of muscle disease. This group is named Limb-Girdle muscle dystrophy, which is a genetically inherited condition that primarily affects skeletal muscle and leading to progressive proximal muscle weakness, especially the presentation of the symptoms caused by a loss of muscle fiber. So the Limb-Girdle muscle dystrophy 2E was recently reclassified as Limb-Girdle muscle dystrophy recessive type 4, Lgmb R4, which is a rare type of recessive muscular dystrophy caused by the lack of beta-sarcoglycan. You can see here the whole name of the different mutation affecting sarcoglycans and the new name in this reclassification. And the conformation of the muscle is prevalently at the proximal, upper, and lower limbs. So the LGMD, the Limb-Girdle muscle dystrophy, are progressively debilitating muscle wasting disease. There are actually no therapies. It's possible to treat in some cases patients with the corticosteroids and other drugs are actually in use to prevent the progression of cardiac disease, which is one of the symptoms, and also the respiratory compromission. The Limb-Girdle muscle disease affects males and females equally. They affect the skeletal muscle, they affect cardiac, respiratory system. There is an elevated creatine kinase levels. The symptoms often develop before age 10. There is a loss of ambulation, often in early teens. And the more severe forms are quite similar to the Duchenne muscular dystrophy, which is a different muscular dystrophy, very aggressive, with other peculiar symptoms. The death can result before age 30. And among the LGMDs, we have sarcoglycans, which are proteins very important to prevent muscle damage during contraction. All four functional sarcoglycans must be present to form a functional sarcoglycan complex, and which include the beta sarcoglycan, the alpha sarcoglycan, and the gamma sarcoglycan. Sarcoglycan deficiency leads sometimes to dystrophin deficiency. Not always this is the case, but sometimes it happens. You can see here the complex of sarcoglycan on the sarcolemma membrane, and we find with different proteins, including the dystrophin protein. And the beta sarcoglycan is fundamental for the function of the sarcolemma membrane. So there are several muscular and also extramuscular manifestation the diagnostic clues for LGMD subtypes. I just highlight what's happened in sarcoglycanopathies, in particular concerning the scapular winding, the compromission of the respiratory muscles, the diaphragm, the muscle pseudohypertrophy, the heart compromission. Around 60% of beta sarcoglycanopathies suffer from dilated cardiomyopathy. Respiratory failure is leading cause of death in this disease that is nowadays successfully prevented using non-invasive ventilation. And there is also the presence of respiratory and heart dysfunction that make LGMD4 close to Duchenne muscular dystrophy, as I mentioned before. In the point of view of expression of the protein is expressed on the sarcolemma membrane. You can see here the staining for the expression of the protein using antibodies against the beta sarcoglycan in normal healthy muscles. And here you can see what's happened after the mutation of beta sarcoglycan in different patients. You can see also a sort of degree of expression of variability of expression is sometimes is absent, sometimes is present less than 30% or much more than 10%. In terms of muscle phenotypes, so we can distinguish muscle necrosis, muscle fiber necrosis. We can distinguish also fat infiltration, fibrosis. In some cases, also inflammatory cells coming out, and all these features characterize the loss of muscle function. MRI is very important to characterize the compromission of the different muscles. You can see here the thigh and the calf muscles by MRI in T1 images. And I have to say that there is a particular compromission and variability in the compromission of the muscles. I mean that in sarcoglycanopathies, you have the vastus lateralis and the sartorius and the gracilis muscles, which are affected. But there is also a degree of affection along the muscle fibers. Not all the muscle fibers are affected at the same time. You can have some damage in different parts of the muscle fibers, leading to a variability in the compromission of the muscle in terms of geometry, architecture. And this is also the same case for the heart, where you can observe in different parts of the heart a different degree of compromission. The end of the cardiomyopathy is always the dilated cardiomyopathy, but the starting point is caused by a different degree of muscle fiber compromission. So this is very important because by the understanding of the differences in the muscle damage along the muscle fibers, between the muscle districts, between the muscle tissues. It's possible also to understand the clinical variability of patients and also to understand the onset, which is different in the patients affected by mutation of beta-sarcoglycan. So the MRI is very important, as also the genetic evaluation. There are different pathogenic variants which have been described in different cohorts of patients. The mutation are prevalently missense and nonsense mutation, French mutation, deletion. Also, one of the most characterized mutation is the truncated mutation in the exon 3, C334. Which cause a very aggressive disease and progression of disease. The frequency of the mutation is quite similar. There are some difference in relation of the number of patients which were characterized in the different cohorts. This is a study recently published in neuromuscular disorder, and you can see here that the frequency in the European cohort is different than the Brazilian, the Netherlands, and the USA, but the range is between 17 and 37%. The patient tested, the total patient tested in this cohort are affected by a different mutation in the sarcoglycan. So it's possible that the mutation in the beta-sarcoglycan gene may affect different tissue, and the pathway involved on that probably are the explanation of the diverse decline of muscle and cardiorespiratory function. So the evolution of the clinical features with aging in LGMD4 have been characterized in different studies. I just pointed out the analysis published recently in this work of the group of Diaz-Manera. In reality, it was a collaboration between different groups in Europe, and they analyzed the influence of age, of onset of symptoms on the time to wheelchair. They use a Kaplan-Meier to estimate the aging age at a wheelchair based on the age of patients stratified in two groups with onset before and after 10 years old. So you can see here in dark lane the patients stratified with an onset disease before 10 years of age. And in blue, the blue line is related to the patients onset after 10 years of age. And you can see here that there is a correlation between the loss of ambulation and the onset of symptoms, meaning that if we are in the presence of a loss of ambulation, probably we have to take care about the onset of the symptoms in order to stratify better the patients when we perform analysis. In the same paper, they try also to correlate if there is some correlation between the percentage of protein expression and the loss of ambulation, and they did not find any kind of a significant difference in this sense, even in considering the fact that more than 30% of patients, the 8 patients from this cohort of beta-sarcoglycanopathies have an increase, the presence of beta-sarcoglycan positive muscle fibers, more than 30% of these muscle fibers, and 29 patients have less than 30% of expression of beta-sarcoglycan, and 22 patients show the absence of the beta-sarcoglycan. So the early onset and low protein expression in muscle biopsies less than 30% are probably independent risk factors for loss of ambulation before 18 years of age in sarcoglycanopathies. And this is also a consideration that we can take in consideration also for beta patients. What about the prognostic significance of cardiac and respiratory involvement in sarcoglycanopathies, in particular in beta-sarcoglycanopathies? So there is a diagnostic delay. There is a significant diagnostic delay. We have to take care about that, especially considering the groups of patients affected by mutation in alpha-sarcoglycan and gamma-sarcoglycan. The loss of ambulation is quite similar between groups, and the cardiac involvement seems to be prevalent, even not significant in patients with alpha mutation, in alpha patients. And there is the respiratory support is quite. So cardiac is involved, and as well also respiratory function is involved, and the authors perform a Pearson test also to show statistically significant correlation with the age, with the cardiac involvement, to detect also if there are some particular increase or decrease of activity in the different groups of sarcoglycan patients. And in this case, they concluded that there is an involvement, but there are not significant difference between the groups of sarcoglycan. So we performed this clinical study to evaluate the clinical determinants of disease progressions in patients with beta-sarcoglycan gene mutation. So the aim of the study was the evaluation of cardiac and respiratory muscle activity during disease progression in order to prevent cardiac and ventilatory insufficiency, improving the management and the quality of life of LGMD4 patients, and to also evaluate if it's possible to identify markers or clinical markers for the new gene-modified therapies or pharmacological therapeutic strategies which are coming out. The study was designed as a 10-year observational retrospective study. We highlight the significant correlation between CK, cardiorespiratory assessments, and disease progression over years. And we also evaluated the interconnection between variables. So we recruited 26 patients with a genetically defined diagnosis, ranging in age from 8 to 55 years, and with data collected on at least 3 different evaluations. Patients were enrolled within the group of familial beta-sarcoglycanopathies, Italian group, Italian network, and the patients were followed in different centers in Italy. And we take in consideration the patients who made at least once or twice evaluation per year, which mean a total of 542 evaluations, which include a neurological, cardiological, and the respiratory examination. The study was approved by the ethical committee of the Polyclinical Hospital of Milan and was registered with this following number. we recorded genetic, histological, immunohistochemical tests that led to diagnosis. And also we included in the study the neurological, of course, cardiological and respiratory examination performed over the years. The blood test, we recorded spirometry, also vital capacity, the forced vital capacity, the forced expiratory volume in the first second, FEV1. And we also recorded the ejection fraction collected from the echocardiogram. The patients were analyzed as a total group, so all 26, or they were stratified in two different groups, carrying group A and homozygous or in compound heterozygous truncated mutation in exon 3, not to cause the severe disease, and group B for patients with the other kind of mutation and gene alteration. In our cluster, the group A included 12 patients, 6 men and 6 women with a median age of 25 years old. And the group B included 14 patients, 7 men and 7 women with a median age of 32 years old. Here you can see the demographic and the clinical data of the enrolled patients, stratifying the different groups, group A and group B, with the different age of onset, the sex indicated here, the last evaluation, the walking capability, so yes or not, the last evaluation, the loss of ambulation, the presence or absence of steroid therapy, the heart compromission, the respiratory compromission, and also the motor function assessments related to the 6-minute walking test and the other scale like North Star scale. As you can see here, most of the patients were not in the condition to be tested by motor function scales. So this was a limit of the study because we cannot include these analysis and correlation analysis with the cardiorespiratory assessments. And the other demographic and clinical data are related to the MRI analysis that they perform and the characterization by MRI of the different districts of muscles, the proximal upper and lower limb compromission, the presence of or absence of atrophy, the presence of or absence of fatty replacement and degeneration assessed by MRI. Also the history of surgeries, so anatomy, or in the case of one patient, heart transplantation. So what about the results? So we take care about multiple parameters, and we try to correlate age with the different values, cardiorespiratory values, CK values, in terms of mean of adjusted value. So if we are in the presence of at least 2, 3, or more evaluation, we consider the mean value of the different assessment in the same years per year. So we first analyze the correlation between clinical outcome and disease progression over years using the age as the independent variable. And the analysis we perform using generalized linear models, which mean linear regression models with which fit with the dependent variables such as CK, EF, BC, FBC, and FEV1. And the results show that the CK value assessment show a significant decrease trend over the years. You can see here the global patients included in the study, all the patients included in the study. Here you can see the age of the different patients, and in y-axis you have the CK values. This is the stratified group A. So patients affected by a truncated mutation in the exon 3. And here you can see the group B, so the other mutation. So the group A shows a clear homogeneity in the decrease of CK over the years. So the trend and the slope is very interesting in terms of decrease and significance of a correlation between CK and the age. Otherwise, in the group B, with different mutation, probably less affected than the group A, the correlation is not significant, even is significant, but the slope is lower and lower, and the progression. So the group A showed a constant decrease of CK values with a significant regression according to the age. And the group B was more stable, and the regression was less significant compared to the group A in terms of correlation with age. What about the cardiac function? So in this case, again, you have all the patients included in the study, group A, group B. So considering also the progression of the disease, which is particularly aggressive in this group of patients, they start with less ejection fraction percentage. And in this group, the decrease trend is much severe compared to the group B, the patients of the group B, and it's also related to a few years of range. So we have a severe decrease in few years in group A compared to the group B. The group B patients also suffer from cardiac impairment, but is still slower in comparison to the group A, and the slope is lower in comparison to the group A. So both groups were observed, we observe in both groups a significant relation to the age. And we have also to take into account that both group patients assume beta blocker, assume therapy to prevent the progression of dilated cardiomyopathy. We also take in consideration the spirometry values. So we compare the spirometry differences, the spirometry value differences between the group of patients, stratified patients. As you can see here, that the group A is again much more, all the data, all the values are much more closer. The progression is significant, the correlation is significant, especially VC decrease rapidly in group A than in group B compared to the group B. FABC show a significant lowering rate in group A versus group B. And the same is for all the groups, all the patients that were evaluated in the globality of the study. So we also try to correlate the time to event analysis for the time from disease onset to loss of specific function related to motor or cardiac or respiratory assessment. Well, we try also to reduce the uncertainties which are caused by the lower number of patients that we included in the study, and also variability of their follow-up. And so we considered the disability events as age of loss of ambulation, age of introduction of cardiac medication, or age of introduction of respiratory support. And the Kaplan-Meier analysis demonstrated a faster rate of decline about the time of loss of ambulation and introduction of respiratory support in patients, again, of group A. The group A here is indicated in red. The red line is group A, and the blue line is group B. So, as you can see here, the rate and the slope of the curve is particularly aggressive in group A compared to group B in terms of age at loss of ambulation and in terms also of age of respiratory support or introduction of respiratory support. No significant difference were observed among groups concerning the cardiological support. Probably because they start very early, the treatment, the cardio prevention treatment. But in any case, all these data highlight the severe disease course of the group A patients carrying condition on exit. We also try to verify if there are some correlation between variables. So there are some variables which are age-related, as demonstrated in the cardiac assessment, correlating cardiac assessment and respiratory assessment. But we also try to analyze if there are some independent correlation, so not dependent on the progression of the disease, not depending on the age. And this is the reason why we created the different models of multivariate generalized linear models. So these models were created especially to define if there is some association to the disease progression over the years or some independent variables that can be taken into consideration. So what we found is that in particular EF, so the ejection fraction performed during the echocardiography is significantly lower with disease progression, so regardless to CK, meaning that probably this parameter, the EF, was the strongest independent marker of disease progression. This is very important because patient loss probably the muscle, and also CK is reduced for the loss of the muscle. But the reduction of EF seemed to be independent of the decrease of CK, of the decrease of the muscle activity or function and age, meaning that probably there is another parameter that we can take in consideration, another pathway specific of the heart that can be also present during the progression of the disease independently of the skeletal muscle. So the conclusions. Both respiratory and cardiac function show a significant decrease over years. The worsening of muscle function is carefully described by decrease in CK, which has proven to be not only the simplest and less expensive parameter to closely follow the disease progression, but also to predict clinical outcomes, such as the need to introduce a respiratory support, for example. Among respiratory variables, vital capacity, forced vital capacity, for the respiratory vital volume, were significantly correlated with the age, in particular in group A, which is the most affected. And it is important to notice that spirometry seems to be rarely performing in group B, probably because of the relative benignity of their conditions. The scarceness of data certainly affected the reliability of our results. On the other hand, we can emphasize the importance of yearly spirometry follow-up to measure vital capacity as predictor, force vital capacity as predictor of the respiratory insufficiency that can be treated by non-invasive intermittent positive pressure ventilation with nasal masks, for example. Cardiac parameter EF was the biomarker that mostly steadily decreased with aging and disease progression. Most importantly, the association between this assessment decline and disease progression was independent of the rate of decrease of CK and the spirometry. So we need to increase these results by other studies, increasing the number of patients evaluated. But we believe that the EF could be a good candidate as a cardiac marker for estimating the beta-sarcoglycanopathy progression, regardless of the therapy, and its use should be implemented through the patients to predict and prevent heart failure. Finally, we confirm the more severe muscle damage and therefore a worse disease course in patients with the truncated mutation in exon 3, both in homozygous and heterozygous. And we believe that these group of patients have to be carefully evaluated during a clinical study, especially genetic clinical study and other treatment studies, because we know that the behavior, the clinical behavior of this patient is quite different. So there is probably an advantage, because if you are in condition to promote a rescue of the disease, you can observe better this rescue probably in this group of patients. So the more affected ones, especially at the beginning, at the onset of disease. But if you are in the presence of amelioration, for example, based on different treatment, gene therapy or other kind of treatments, probably the group A is very tough. Is very difficult to predict the response in this group of patients. At the same time, we have to say that in group B, there is an heterogeneity. There are less affected patients, there are mild affected patients. And so this increased the variability, and the outcome in that case have to be carefully addressed. We also believe that cardiac function ejection fraction assessment could really improve the outcomes in terms of future clinical trials. It could be a very, very good candidate for estimating the response to the disease. However, as I said, our results must be treated with caution, and we require future more detailed statistical analysis with a high number of patients to corroborate the reliability of our observation. This is why I would like to point it out an ongoing clinical study, a study of the natural history of patients with different limb-girdle muscle disease, including patients affected by beta-sarcoglycan mutations. And this is an observational longitudinal study. They promoted by Sarepta. They plan to analyze different motor function assessment, North Star scale, time to rise from the floor, time meter work. They also include some pulmonary function tests, like a force vital capacity. We believe that this study will be very important and to better understand the progression of the disease in presence of mutation of beta-sarcoglycan gene, and also to improve our knowledge for future therapies in a clinical point of view. So this is very important. There are other studies probably coming out, but we are very happy to participate in this study. I would like to thank you all, and I'd like to thank all the members of my groups, and thank you very much.
Okay. Hello. We're going to show, first of all, a video that sums up all the topics of my presentation.
In the world, there are thousands of children and adults suffering from beta-sarcoglycanopathy and other rare forms of limb-girdle muscular dystrophy. That's why we at GFB Onlus have been by their side since 2010. GFB is in fact the only association in the world that specifically deals with this little-known disease to give all patients and their families the opportunity to face it with serenity. We collaborate with institutions and research organizations around the world to develop increasingly targeted treatments for this rare form of dystrophy. In recent years, science has made important progress thanks to the use of gene therapies that are helping us in the treatment of LGMD. Our goal is to extend these therapies to as many patients as possible. In 2021, we launched the Quality Project in order to scientifically study the international network of LGMD patients and test the effectiveness of the new treatments. Through specific international questionnaires, we are able to collect scientific information on the evolution of the disease, the quality of life, and the psychological well-being of patients. Not even language barriers have stopped our mission.
For the Quality Project, we are using the technology at our disposal, and so we are connecting with the patients in order to help them to fill in the form. And we are using Zoom, and at the same time we open a page in Google Translate. So we write the question we want to ask, and we do copy and paste, so the patient can listen to the question in his or her language.
Какое заболевание у вашего ребенка и сколько ему лет?
Quality is an important tool for LGMD research and helps to overcome the current lack of patients' data. We ask to the Muscular Dystrophy Association, Clinical Center and LGMD 2D, 2E, to see patients of all the world to join the project. GFB will guarantee that in the future all institutions, researchers and industry will be able to use these data to improve the quality of life of our loved ones.
To join the Quality Project, just write an email request to info@beta-sarcoglycanopathy.it. Limb-girdle muscular dystrophy affects everyone in the same way. There are no differences among the different countries, cultures, or languages. Together, we are stronger.
Our association, GFB, Gruppo Familiari Beta-Sarcoglycanopathy, has been supporting scientific research projects for over 10 years in order to improve the quality of life of people affected by limb-girdle muscular dystrophy type 2C, 2D, 2E, or R5, R3, R4. GFB have funded the LGMD 2E R4 gene therapy preclinical part, and in 2018 they started a natural history study on Italian patients affected by sarcoglycanopathies. In recent years, GFB have been committed to research other families involved in these diseases all over the world, and currently there are 600 families that refer to our association. Lack of data. Today, it is very difficult to start clinical trials for these diseases, as available patient data are still too few. The natural history of these diseases is little known. We need in-depth scientific studies on these patients. This slows down the search for a cure for our loved ones. Scientific data are needed. In order to be useful for scientific research, the collection of data must be carried out in accordance with the precise criteria in a systematic and scientific manner. Only in this way can it be used to assess the impact of new therapies. Homogeneous data are needed. In addition, the collection of data should be as homogeneous as possible. Everyone should use common schemes and procedures. Everyone in different countries, in different associations, in different languages. What can patients and associations do to help the scientific world treat these diseases? The Quality Project. GFB is trying to help the scientific world and in 2021 started the Quality Project. It's an international project with the aim of studying the quality of life of patients affected by sarcoglycanopathies LGMD 2C, R5, 2D, R3, 2E, R4, promoted and funded by GFB. The project is developed in collaboration with Dr. Ivan Torrente, Director of the Laboratory of Stem Cells at the University of Milan, and neurologist of the Dino Ferrari Center, Fondazione IRCCS Cagranda Policlinic Hospital of Milan. Who can participate? All the patients affected by LGMD 2C, 2D, 2E, patients from all continents, all associations of neuromuscular disease, LGMD groups and patients' Facebook groups, clinical reference centers for patients. What data are collected? The questionnaire to be completed by patients consists of the following parts: informed consent, personal data registry, active limb. This scale measures a patient's ability to perform daily activities requiring the use of the upper and or the lower limbs, whatever the strategy involved. Abiland, EK scale, clinical questionnaires, and PEDS-Q, AL. We are considering the addition of the questionnaire promise. The questionnaire may be completed in two ways, on the file Word or on the form created on the GFB site. The questionnaire can be filled out directly by patients, even from their home. To join the Quality Project, just write an email request to info@beta-sarcoglycanopathy.it. Support in compilation. GFB staff ensures support in the compilation of questionnaire with Zoom video calls, phone calls, or emails. Interpreters. GFB faces language difficulties with the help of 12 interpreters who communicate with patients in English, French, Spanish, Portuguese, German, Hungarian, Romanian, Russian, Ukrainian, Arabic, Turkish, Persian, and Hindi. Who's participating? 5 patients associations interested in taking part of the Quality Project. 2 clinical centers have already joined. 25 the patient states of origin: Europe, Italy, Serbia, Germany, France, Norway, Spain, Greece, Switzerland, Portugal, Hungary, Denmark, Russia, Ukraine, America, Argentina, USA, Colombia, Canada, and Brazil, Asia, Turkey, Syria, Pakistan, Japan, Iran, India, Africa, Tunisia, and Oceania. 292 patients enrolled in the project with the following diseases: 28 affected by LGMD 2C R3, 109 affected by LGMD 2D R5, 155 affected by LGMD 2E R4. 76 questionnaires already completed, a code assigned to each patient. Data management takes place according to these 3 steps. GFB received the quality questionnaire from the patient association group. GFB bind the code to each patient and transcribe the collected data with their code into the 2 Excel files containing all patient data except personal data, which may allow recognition. The code shall consist of a number, the type of disease, 2C to D to E, the association or group of provenance. The data associated with the code in the Excel tables are sent to the research center. The part of the GFB quality project, info@beta-sarcoglycanopathie.eit. At present, a lot of LGMD associations and groups are being created all over the world. Each of them works well, but individually without comparison with others. The GFB's dream, a Limb-Girdle muscular dystrophy coordination of associations. The GFB's dream is that from this international conference and the quality project, LGMD associations and groups get to know each other better and start thinking of common objectives and projects, maybe even through an international coordination. Limb-Girdle muscular dystrophy affects everyone in the same way. There are no differences among the different countries, among different cultures or languages. Together, we are stronger. So, GFB, thanks for the collaboration, Dr. Ivan Torrente, Dr. Carlos Sanchez Riera, and Mrs. Kathryn Bryant. Thank you very much.
Hello to everyone. I'm very happy to be here to share, even though online, my story concerning the use of CFTR correctors in sarcoglycanopathies. Let me first thank the International Limb-Girdle Muscular Dystrophy Conference, and a special thanks to the GFB group and Beatrice Vola, who invited me. But let's start. Thanks to the very nice presentation, let me see if I'm able to go on. Okay, I will skip these 2 first slides concerning the general information regarding sarcoglycanopathy, this one and also this one, thanks to the beautiful presentation of Dr. Torrente. And I would like to focus just a little bit on the fact that sarcoglycanopathy are rare diseases without a cure presently. And besides the symptomatic treatments, there is no effective therapy acting on the cause of the disease. Of course, you well know that gene therapy did very fast step forward in this last time, but my work is devoted to the search for a pharmacological therapy of sarcoglycanopathy. To have this, we need to have an in-depth knowledge of the pathogenic mechanism of the disease, because we want to identify something, small molecules, able to act on the primary or secondary causes of the disease. And so let me enter in a little bit more detail on the sarcoglycans, that are 4 proteins, mainly expressed in striated muscle. They are known as alpha, beta, gamma, and delta sarcoglycan. They form a unit, a complex that is part of the major dystrophin-associated protein complex. They are located on the sarcolemma of striated muscle, where they play a very important structural role. my data will be mainly on alpha-sarcoglycan, but remember that they are, for most of the cases, superimposable on the other proteins, on the other sarcoglycans. Sarcoglycans are co-translationally translocated into the endoplasmic reticulum, where they undergo maturation, so glycosylation, folding, and when all the 4 subunits are properly gain the native structure, they can form the complex that eventually leave the endoplasmic reticulum and go to the sarcolemma, where they are included in the dystrophin-associated protein complex. Here is what you can see in an adult biopsy, staying with the 4 different antibodies against the sarcoglycans. Because of the many interactions that the sarcoglycan complex have inside the DAPC, they play a very important role in the stabilization of the entire structure, and thus in protecting the sarcolemma from damages caused by muscle contraction, by the stresses of muscle contraction. Another important evidence of the role of sarcoglycan is that when we have mutations in the genes coding sarcoglycans, we develop a severe form of skeletal muscle dystrophy that are sarcoglycanopathies. We know that there are many different types of mutation, and in these graphs are represented the whole types of mutation in sarcoglycan genes. And as you can see here, most of them are of the missense type, so or small in-frame mutation. This means that a full-length sarcoglycan is produced with just one single amino acid changed or missing. Of course, there are also other mutations that leads to the complete abrogation of the synthesis of the protein, such as the null or in-frame or out-of-frame mutation. But what happens when we have this mutation in a sarcoglycan gene? The very important point is that when there is a mutation in one gene, we can observe that even the wild-type partners are severely reduced or even lost from the sarcolemma. Of course, you can imagine that this can alter the structural properties of the DAPC. There is an alteration in these properties because of the loss of function, because the sarcoglycan complex is missing. And of course, this can lead to some damages in the sarcolemma and, for sure, the progressive muscle degeneration. It's important to remember that, and also Ivan Torrenti described this, that the disease severity is inversely related to the residual amount of sarcoglycans present at the sarcolemma. Sorry. A few years ago, we contributed into the understanding on the pathogenic mechanism of the disease. Because what happens when we have a very small mutation? The point is that the protein is unable to gain the proper fold, so is unable to gain the native conformation, is folding defective, is recognized by a very complex system that is called endoplasmic reticulum quality control and endoplasmic reticulum associated degradation pathway that deliver the proteins with the mutation outside the endoplasmic reticulum. During this process, the protein is modified by the addition of a polyubiquitin chain, and this is the mark for the protein being degraded through the proteasome. So this leads to the loss of function, because the sarcoglycan complex cannot be produced and delivered to the sarcolemma. We also observed that if we block any one of the different steps of this pathway, it's possible to reduce the degradation of the protein, allow additional rounds of folding, and allow the assembly with the wild-type partners and gaining the membrane localization. And here you can just have one example of by inhibiting the last step, the proteasome. You can see that nothing is on the plasma membrane without the treatment, but the signal is coming from the plasma membrane upon treatment. So we can imagine that the sarcoglycan mutants can keep the structural function. However, blocking this process that is used by cells in many other situations could have side effect, and therefore we thought that it would be better to act on the other part of the story, so on the process of folding. In which way? Try to use small molecule able to help the protein to gain a native or native-like structure, allowing therefore the assembly and the traffic to the sarcolemma. Also in this case, the sarcoglycan keep the structural function. The point is which kind of small molecule to use. In this, we have a very strong help by the study of the cystic fibrosis. That is another rare disease, less rare than sarcoglycanopathy, but that is due in several cases by mutation of a protein that is the CFTR protein, cystic fibrosis transmembrane regulator, that present a similar mechanism of our sarcoglycan mutants, because these mutants present a small mutation and they are affected in folding and traffic. The cystic fibrosis field has a lot of work and also a number of molecules that have been developed to treat the disease. Among these, there are the CFTR correctors that are small molecule effective in rescuing on the plasma membrane the CFTR mutants that are defective in folding and traffic. And so our idea was, why don't try to use these small molecules also to treat sarcoglycanopathy? Thanks to the Cystic Fibrosis Foundation, we gain a number of these small molecules that we used, that we tried first in vitro and then in vivo. Besides the experiment performed in a cell model, I would like to show you just the experiment in vitro performed on myotubes from patients with alpha-sarcoglycanopathy. So human specimen derived from a small bioptic fragment that we had thanks to the Italian Telethon Foundation biobanks, and thanks to the help of Marina Fanin, that was a friend of ours that is no more with us. She helped us in obtaining these cells and also in differentiate these cells in myotubes that are the first step of skeletal muscle differentiation. These cells were used to test the CFTR correctors. And here is just an example. Here you can observe the myotubes from this patient treated just with the vehicle of the correctors. And you can appreciate that there is a very faint signal coming from the sarcolemma. However, when we treat for 3-4 days with CFTR correctors, you can observe that there is a strong relocalization of the signal at the level of the sarcolemma with several different CFTR correctors. We also perform an experiment in vitro to evaluate the if we were able to improve also the strength of the sarcolemma with positive result. I cannot show you because of time, but we were also able to evaluate this. The last experiment that I would like to show you in vitro is this coming from myotubes of a patient with beta sarcoglycanopathy, so LGMD4, carrying this missense mutation. Also in this case, you can observe the increase of the content of the mutated sarcoglycan and the presence of the sarcoglycan at the level of the sarcolemma upon treatment. So we can say that the in vitro proof of concept was established of the treatment of sarcoglycanopathy with CFTR corrector. And so what next? Testing the efficacy and safety of the best molecules in animal model that should carry a missense mutation in the sarcoglycan gene, in one sarcoglycan gene. This was the most challenging part of our work because the knockout animals are not usable because they do not have the sarcoglycan. Do not express one sarcoglycan. And unfortunately, the knocking animal with mutation similar to the human one did not develop a dystrophic phenotype. We can talk about this for a long time, but we had to overcome this problem. And to do this, we adopt an alternative strategy in which we generated an animal model that is humanized at the level of the hind limbs. In other words, we have the background of the alpha sarcoglycan knockout. So this mouse does not produce the alpha sarcoglycan. And by using a viral vector, we introduce at the level of the muscle of the hind limbs the human sequence of alpha sarcoglycan in the wild type or in the mutated form. We did this in a very early stage, so in pups of 1-2 days, newborn mice, and we observe what happens at the end of 10 weeks. In this manner, the mice were able to grow with the presence of the human sequence, and we expected to see a healthy phenotype when we introduce the wild type sequence of alpha sarcoglycan and the dystrophic phenotype by introducing the mutated form. And here are our results. So this is for comparison, the healthy phenotype of a wild type mouse. This is the phenotype of the dystrophic alpha sarcoglycan knockout. You can see the problem at the level of histology and the absence of the signal of sarcoglycans at the level of the sarcolemma. When in this background we introduce the human alpha sarcoglycan wild type sequence, you can see that we develop a nearly healthy mice with amelioration of the histology, but what is important, the signal of the sarcoglycans at the level of the sarcolemma. However, when we introduce the sequence of the mutated form of alpha-sarcoglycan, you can see that there is the development of the disease, the dystrophic phenotype, and almost nothing is observable of the signal of sarcoglycan subunits at the sarcolemma. So this mouse seems to faithfully mirroring the disease and was used for the treatment with the CFTR correctors. Basically, this is the protocol of our experiment. So we introduced the viral vectors in the hind limb of the pups, and starting from 7 weeks after the injection, we start the treatment with the C17 CFTR correctors by systemic administration through intraperitoneal injection. We did daily injection for 3 to 5 weeks, and I will show you just the 5 weeks of treatment data. At the end of the treatment, we analyze the function of the muscle. So the force, we measure the force of the muscle, and we perform the biochemical analysis. First of all, I would like to say to see that the muscle, the mice growth was normal during the entire period. They gained the same weight, both treated with vehicle and with C17, with no problem at the level of kidney and liver. That should be the organs for the metabolism of this drug or compound. And so we can say that the CFTR correctors has a safe profile. We analyze at the level of muscle, and we can show the improvement of the phenotype histology. We can observe the sarcoglycan at the sarcolemma, and also the entire sarcoglycan complex in a similar way of the healthy mouse. But the very last thing, so the CFTR corrector C17 rescue the sarcoglycan complex on the sarcolemma in vivo. And finally, the last very important experiment is the functional outcome. I don't want to enter in the detail of the setup, but we were able to measure the force of the tibialis anterior muscle. And here you can observe that the alpha-sarcoglycan knockout, so the negative control, has this force. The vehicle treated has this force, very similar, but when we observe the muscle from mice treated with C17, we observe an improve of the force that is very, very similar to the wild-type one. So the point is that CFTR corrector rescue muscle functionality. So to conclude, we have set up a pharmacological approach specifically addressing the forms of sarcoglycanopathy due to missense mutation that, remember, are the majority. So a large number of patients are potentially eligible for this therapy, pharmacological therapy in the future. That is based on small molecules, so they are easy to administer, they can reach the whole body, they can be easily produced and also optimized, and there is a reduced patient compliance. By the way, we can also imagine to design a combo treatment with compounds targeting the primary, so with the CFTR correctors, together with something targeting secondary effect of the disease. And finally, this is potentially applicable to other orphan diseases. I will skip the ongoing project, but I would like to give you a take-home message in which we have tested the CFTR corrector in vivo, collecting very promising data on alpha and beta sarcoglycanopathy cells. And then we have these in vivo experiments showing that it's possible to recover a partially unfolded proteins, folding defective sarcoglycans, together with the other on the plasma, on the sarcolemma, improving the phenotype and the force. Last but not least is the thanks to all of you and my lab, that are all these guys here, who is no more working with us because they live or retired, and the many collaborators around Italy and the world, and of course who founded our research, and all of you. Thank you very much.
Okay, good morning to everyone. Thank you to invite me to do this presentation. My name is Carla Sanchez, and I am working at La Sapienza University of Rome, and I'm going to speak about our project about muscle diversity. In this presentation, I will introduce you a little bit the concept of muscle complexity and muscle diversity. I'm going to speak a little bit about why we need to study muscle diversity. And finally, I'm going to explain about what we need to consider to succeed in these studies. So, muscle tissue is made from muscle cells, and this is how they look like in a laboratory. The cells can grow up, and when they touch each other, they fuse until they generate these long tubular multinucleated structures called myotubes. These myotubes have the capacity to contract, to spontaneously contract. And these are happening in a laboratory where the conditions and the environment are very, very controlled. In the muscle, we have a little bit a different situation. So in the muscle, these myotubes now here are grouped in fascicles, and these fascicles build the muscle. Now, if we cut this muscle and we observe it in histology, we observe these myotubes from above, but they are not alone. In the muscle, we found also the nerve, we found also blood vessels, we found immune cells, and we found, of course, the muscular cells. So we have more complex, and we have a tissue with a lot of diversity. And now you need to imagine that we didn't have just one muscle in the body. We have at least 600 muscles. So we have this very complex and very diverse scenario. So why we need to study muscle diversity? You need to try to imagine an extended field of grass. Looking from a side, they look all the same. They're almost all the same. But when we have some problems, we observe that some parts of this field are drying, whereas some parts are resisting to the problem. And that could happen for different elements. That could happen for the genetics of the grass, for the pathogens, for the use, if the kids are playing football on that field, for the ground, for the availability of the sun or the availability of the water. And of course, all these elements are interacting with each other to generate this environment. But the thing is that to study these single elements, it's very important, the importance relies into apply the correct treatment. Because now, if you are, for example, you want to just to change all the grass of the field, and maybe the problem is in the ground, in 2 months, the problem will be again the same. No, for this, it's very important to know very well about these single elements. In the muscles, it happens more or less the same. Looking for a side, they look all more or less the same. But when we have some problems, we observe how some muscles are degenerating, whereas some muscles resist to the problem. And at the time, that happened for the other different elements for the cell populations, bloodstream, and a long list of different elements that, of course, are interacting with each other and generating even a more complex and diverse scenario. So now let's try to see some of them, and let's look how they work. Imagine that this is a muscular cell. Inside of it, we have the chromosomes, and inside the chromosomes, we have the genetic code and also all the genes. From these genes, they are generating the proteins. And the proteins, in the case of muscular cells, are located many of them at the external membrane, giving stability and a role of a structure to the cell. But when we lose this, when we have a mutation in one of the genes, the protein is not generated, and then we lose a little bit the stability of the cell. But if all was about genetic issue, and if all was about the single mutation, we won't expect to have the same problem in all the cells, in all the muscular cells of the body. Instead of that, when we are looking on the MRA in the magnetic resonance, we observe that we have some differences. This is the slide of this is a picture of a magnetic resonance where you can see the representation of the leg in the upper part, the middle part of the leg, and the calf. And in dark color, you see the muscle, and in white, you can see the skin and also the tissue that have been substituted for fat tissue, for fat. And in this picture, you can see how in the same leg compartment, we have some muscles that are resisting the genetic mutation and some muscles close to them that are degenerating. And there are more curious things, and because this is not happening just in one disease or in one of our disease, it's happening in almost all diseases that we know. And for example, when we have some mutation in an activin 5, we observe that we have a resistant pattern of the muscles of the anterior part of the leg. When we have mutations in protein or glucosyltransferase, we observe a resistant pattern in the external part of the leg. And we can have also the opposite example. When we have mutations in collagen 6, we observe that resistant muscles are in the inner part of the cell. So taking all together, we can say that even if our disease are caused primarily by a genetic mutation, there are a lot of different, or there are different elements that they are making really the difference, and we really don't know about them. So now, just take a look on what we need to consider to study this muscle diversity. One of the things that we need to consider when we study this muscle diversity is that there are a lot of muscles, there are a lot of heterogeneity along the body. So it's not the same if we take the muscle, for example, of the head or the muscle of the limb. And this is very clear because they come from different embryologic structures. This is a chicken embryo. This picture is a chicken embryo. And for example, it's well known that the muscles of the head, they come from the cranial mesoderm here in the top of the picture. And for example, muscles from the limb and the trunk, they come from these structures here, repetitive structures that are called somites. And this is important because coming from different places are having these muscles different molecular signatures, and this could introduce a lot of variability in our studies. So we need to compare muscles as closer as possible. Another thing is to consider is the extracellular matrix. Every one of you know that it's not the same to go in the restaurant and order a tomahawk or order a fillet or order a beef brisket. And that is simply because they have different proportion of fat tissue, different proportion of fibrous tissue, and other extracellular elements. Looking on the human body, we also know that the distal parts of our body have longer and bigger extracellular structures, such as tendons or collagen proportion. And now we need to think also that in some of our disease, such as sarcoglycanopathies, there are also in these distal parts of the body, the muscles that have present more resistance to the disease. So we need to study if there are some relation between these two proximodistal patterns. Other things to consider when we study this muscle diversity are the cell populations, of course, the nervous system, that it should present also a lot of variability, the immune system, and epigenetics. But about this, I want to speak in another presentation because I think now the time is almost gone. And just I want to introduce you also a website that we developed for explaining better this project. And I invite you to enter to this diversitamuscolare.it and just take a look, and there you can find also how to give support to our project. Finally, I want to introduce you our laboratory, our lab members that are very committed people with this project, and also the foundations and associations that are giving support to us. So thank you very much.
In the world, there are thousands of children and adults suffering from beta-sarcoglycanopathy and other rare forms of limb-girdle muscular dystrophy. That's why we at GFB Onlus have been by their side since 2010. GFB is in fact the only association in the world that specifically deals with this little-known disease to give all patients and their families the opportunity to face it with serenity. We collaborate with institutions and research organizations around the world to develop increasingly targeted treatments for this rare form of dystrophy. In recent years, science has made important progress thanks to the use of gene therapies that are helping us in the treatment of LGMD. Our goal is to extend these therapies to as many patients as possible. In 2021, we launched the Quality Project in order to scientifically study the international network of LGMD patients and test the effectiveness of the new treatments. Through specific international questionnaires, we are able to collect scientific information on the evolution of the disease, the quality of life, and the psychological well-being of patients. Not even language barriers have stopped our mission.
For the Quality Project, we are using the technology at our disposal, and so we are connecting with the patients in order to help them to fill in the form. And we are using Zoom, and at the same time we open a page in Google Translate. So we write the question we want to ask, and we do copy and paste, so the patient can listen to the question in his or her language.
Какое заболевание у вашего ребенка и сколько ему лет?
Quality is an important tool for LGMD research and helps to overcome the current lack of patients' data. We ask to the Muscular Dystrophy Association, Clinical Center, and LGMD 2D, 2E, 2C patients of all the world to join the project. GFB will guarantee that in the future all institutions, researchers, and industry will be able to use these data to improve the quality of life of our loved ones.
To join the Quality Project, just write an email request to info@beta-sarcoglycanopathy.it. Limb-Girdle muscular dystrophy affects everyone in the same way. There are no differences among the different countries, cultures, or languages. Together, we are stronger.
Hello, my name is Brandi Benton. I live in the Atlanta area in the United States, and I have LGMD 2A. My LGMD story actually begins later in life. I grew up being very active in terms of physically active. I was an avid roller skater. In high school, I danced on the dance team and at school. And I did not have any signs or any history in my family of LGMD. And in my late 20s, early 30s, I was starting to experience challenges with my knee that led to a couple surgeries that eventually led to physical therapy. And in that physical therapy, I was having some changes and challenges with my walking that led me to go see a neurologist. And it wasn't just the walking itself, it was kind of an overall assessment of my body that while I was going for knee therapy on my knee, I was finding other areas of weakness that had nothing to do with my knee, like my arms and mainly my arms and my other leg that wasn't affected. That led to a lot of tests, all the standard tests that you get to get to the diagnosis of muscular dystrophy, and eventually a diagnosis of 2A through genetic testing. I was diagnosed at age 34, and it was at that time that things kind of flipped for me, and things were now about trying to learn to live with this progressive muscle weakening disease. At the time, shortly after my diagnosis, I met my husband. My husband and I met about 2 months after my diagnosis, and I actually had a support in him from the very beginning. Muscular dystrophy has influenced me in a way that allows me to advocate for myself in a way that I thought I knew how to do, and I thought I was doing pretty regularly and easily, but having to advocate for my needs as my condition progresses was a result of me having muscular dystrophy in the first place. I've been able to not just ask for what I need to accommodate my needs, but also to accommodate who I am. I'm much stronger, much quicker to kind of advocate for what I need in other spaces because I've experienced muscular dystrophy and don't want to go without. I have a great, amazing support system. My family, my friends, everybody that I come in contact with is really a support system. I'm so grateful for the Speak Foundation. That was actually my entrance into the idea of having support from people who have LGMD, because that was a thing that I had not experienced before, even heard of before my diagnosis. So I have a great support and community in the LGMD community as well. If muscular dystrophy was cured tomorrow, the first thing I'd probably do is roller skate. I miss roller skating. I miss being active in that way. It was a great stress reliever. And it was also another sense of a sort of community that I was part of, in dancing. Those were two things that I would really get into. If I had any advice for anybody who is newly diagnosed with limb-girdle muscular dystrophy of any type, my first piece of advice is just to find support. Be able to talk to a community, this community. If you're here, if you're watching this, if you're participating in this conference, there's so many people across the globe that are able to support, share your experience, and learn from. I have learned a lot, I have gained a lot, and not just in support, in friendship as well. So get connected to this community, get support from your friends and family, and know that you are strong because you are you, and your muscles and the diagnosis doesn't define you. It actually makes you stronger. Thank you for listening to my story.
If you or a loved one have trouble getting out of a chair, you may also need help standing and sitting in the bathroom, where falls are a serious health risk for anyone with limited mobility. According to the Centers for Disease Control and Prevention, getting on and off the toilet is a leading cause of non-fatal injuries. LiftSeat helps prevent painful, debilitating bathroom falls that could require a move from your home to the next level of care. LiftSeat stands freely and securely over your home toilet to deliver safe, steady support. LiftSeat helps you keep your independence and dignity, and helps you stay in your home.
My parents are on a fixed income. It'd be difficult to keep a home for my father and pay for assisted living or a nursing home for my mom. LiftSeat helps my mother be cared for in her own home.
LiftSeat is especially helpful in protecting people with a wide range of neuromuscular disorders.
My husband has ALS, and I have a bad back. LiftSeat lifts him at a safe angle so he can reach his walker.
LiftSeat smoothly lowers you from a standing position so you can safely toilet on your own. An easy-to-use 2-button controller is all you'll need to raise back up from a sitting position safely, securely, and on your own. LiftSeat easily converts to a powered bedside commode using this washable bucket insert. Simply place LiftSeat next to your bed for close-by nighttime support. Your new LiftSeat will be delivered right to your door, and installing it couldn't be easier. The unit stands securely over your toilet without attaching to the bowl. LiftSeat is the leading powered toilet lift used in hospitals, rehabilitation centers, and nursing homes.
I think LiftSeat can make a big difference in the lives of people that are having some difficulty with transfers, particularly on and off the toilet.
There's not a device that I have seen out there in my 20 years that is stable, that creates an atmosphere of safety and promotes independence for the residents.
Now, the same patented technology trusted by professionals is available for your home. Why risk a painful or costly bathroom fall? Studies show the national average of even a single month in assisted living is $3,500. For a fraction of that, LiftSeat provides years of protection. LiftSeat is even backed by a 100% satisfaction guarantee. For you or your loved one, make the call today. LiftSeat representatives are standing by to answer your questions, take your order, or send you more information. Stay safe. Stay in your home. Order LiftSeat today.
Hi, I'm Kat Bryant Knudson. I wanted to share with you that I was diagnosed with LGMD type 2I in 2006. At that time, there were very few resources for Limb-Girdle. So in 2008, I founded the Speak Foundation to specifically help those living with muscular dystrophy. The one thing I knew is that we needed a way to communicate to everyone in this vast community. So we started the LGMD Patient Network. It is the first patient-led registry for all forms of limb-girdle muscular dystrophy. The LGMD Network is for any individual to join. And when you join, you receive a free subscription to the world's only LGMD News magazine. The magazine brings together researchers, clinicians, and pharmaceutical companies all in one place. We've teamed up to give you the best information that is the latest news for the LGMDs. If you haven't joined our network, please sign up at thespeakfoundation.com. Thank you. Helping others is a huge part of the Speak Foundation. Providing great conferences to our LGMD community is just one of the major things we do. But all these projects and programs could not take place without your generous donations. We want to take a moment to thank all our donors this year who have helped make these programs and this conference a reality. If you would like to donate to our life-saving mission, please go to thespeakfoundation.com. We want to thank you for your support. It means the world to us.
Muscles don't only allow us to move, they also are needed to breathe. When muscles needed for breathing are weakened by limb-girdle muscular dystrophy, this is a major life-threatening complication. Also, some types of limb-girdle muscular dystrophy affect the muscles of the heart. In this segment, clinicians will discuss respiratory and cardiac complications of LGMD. Joining us to share their expertise, we have Dr. Oren Kupfer from the University of Colorado, Dr. Elizabeth McNally from Northwestern University, and Dr. Matt Wicklund from the University of Colorado.
Carol, thank you so much for that introduction. And I hope for all the attendees that you've definitely enjoyed and learned from most of that which has gone on over this past conference. Today, we're going to be talking about the limb-girdle muscular dystrophies. We're going to talk about respiratory and cardiac involvement, or as I prefer to call it, breathing and beating. So the topics that we're going to address are the limb-girdle muscular dystrophies, and we're going to talk about which ones have cardiac and or respiratory involvement, and then we'll also touch on which ones really do not have much involvement. Then briefly we'll talk about why do patients with limb-girdle muscular dystrophy get cardiac and or respiratory involvement. We'll talk a little bit about some of the subtle early signs of cardiac and respiratory involvement. And then finally, we're going to talk about how do we do optimal care for patients with LGMD, and you see a few things listed below. So first, you've heard a lot about the limb-girdle muscular dystrophies during this conference, but essentially the limb-girdle muscular dystrophies are postnatal onset, so meaning after birth, of progressive weakness and muscle atrophy affecting proximal muscles of the lower and upper extremities. And the lower are more affected. I like this view because this truly is the many faces of LGMD. There are many, many different genes that are associated with a limb-girdle phenotype. And when you look at these 5 individuals, if you just saw them walking in the street, you would say these are persons that are just ordinary, everyday individuals walking down the street. But all of these people have a different type of a muscular dystrophy. And just from left over to the right, we have actually Becker muscular dystrophy, which is not officially considered a limb-girdle dystrophy, but it really is. It's a milder manifestation of Duchenne. And then we have a young lady that has FKRP-related limb-girdle muscular dystrophy, a young man with a sarcoglycanopathy, and then next over is a gentleman that has calpainopathy, and finally, a gentleman that has Dysperalenopathy. Many of you now know about the nomenclature associated with the limb-girdle muscular dystrophies. There was an older nomenclature that had, for example, LGMD2A, where the 2 stood for recessive and A was the order in which it was discovered, and those were the calpainopathies. And because we ran out of letters in that system, there's been a change over to the new system. And the new system has LGMD and then D for dominant, R for recessive. And then it's simply the order in which that limb-girdle muscular dystrophy was discovered. And during this talk, we'll talk about some of the limb-girdle muscular dystrophies that were in the new nomenclature, and then some that were in the old nomenclature, and then some that were in one or the other but didn't make the transition. I like this slide because it really discusses just how certain proteins anywhere in a muscle fiber can be involved in a limb-girdle muscular dystrophy. And if you take a look at the bottom right of the screen, you'll see the nucleus. And so there are some internuclear envelope proteins that become limb-girdle muscular dystrophies. To the left of that is the contractile apparatus of the muscle fiber, and there are certain proteins involved in muscle contraction that are part of the limb-girdle muscular dystrophies. In the middle portion of that cartoon, you can certainly see the sarcolemma, which is the muscle membrane. And in the middle, in red and blue, are important proteins, the sarcoglycans and the dystroglycans that are involved in limb-girdle muscular dystrophies. And to the left of that is a trio of proteins that are involved in muscle membrane maintenance and repair. There are also proteins that are outside of the muscle fiber in that extracellular matrix you'll see as we keep moving up and out of the muscle fiber. And then even all the way up outside of the muscle fiber into the extracellular matrix, the collagen disorders, collagen 6 and collagen 12, are also associated with a limb-girdle muscular dystrophy phenotype. So pretty much, if you have involvement anywhere in or around a muscle fiber, you can develop a limb-girdle muscular dystrophy phenotype. This also shows that there's significant overlap between the muscular dystrophies of the limb-girdle muscular dystrophies and other muscular dystrophies. And so in the middle, you'll see LGMD, of which there are a number of proteins listed, and those are actually the genes associated with those proteins. And you'll also see, though, that there are Nemelin disorders, distal myopathies, and distal muscular dystrophies, congenital myopathies and congenital muscular dystrophies, and then other disorders that are associated with a phenotype that is a limb-girdle phenotype. And so there are certain genes that can cross from one spectrum to another. An example certainly being Dysperalenopathy, which is LGMD 2B or R2, which can present predominantly proximally or predominantly distally, but in truth, it's a little bit of both, and so we'll consider them as one. Next, this is just a, I think still the most current look at the prevalence, the relative prevalence of the limb-girdle muscular dystrophies, and this was from 4,000 plus genetic samples that were submitted between 2013 and 2015. And what it demonstrates, again, going from left over to the right, is the prevalence of the limb-girdle muscular dystrophies, certainly in the United States. In different countries, there may be greater prevalence of certain disorders, but in the United States, the calpainopathies are the most prevalent, followed by, to the right of that, the dysperalenopathies, the collagen 6 disorders, the sarcoglycanopathies, anoctamin 5, FKRP, and then a number of the others. So what I'd like to do now is talk a little bit about some of the common limb-girdle muscular dystrophies, and then also make sure we talk about whether or not there is cardiac and or respiratory involvement in that subtype. And that's important for the common muscular dystrophies that are limb-girdle muscular dystrophies, so that you're aware of whether or not this should be a significant concern for you or not. And then also you can educate your care providers about whether or not they need to make sure they address these issues. We talked about the most common of the limb-girdle muscular dystrophies are the calpainopathies, so LGMD R1, and then the dominant form D4. Overall, it is probably the most common, and it makes up perhaps 15% of the limb-girdle muscular dystrophies. There are dominant and recessive forms, as I mentioned. Generally, the onset in the recessive form is in that age range of 5 to 20 years of age. And actually, the dominant form is maybe another decade or two later than that. This particular disorder has predominant sparing of the quadriceps, so the muscles on the front part of the thigh, and that's very important for maintenance of walking. There really is not any significant heart involvement in the calpainopathies, and there can be, though, some gradual respiratory insufficiency later in the course in calpainopathies, such that non-invasive ventilation might be needed later in the course. The Disperalenopathies, so LGMD R2 or 2B, those are perhaps the second most common of the limb-girdle dystrophies. In the United States, it may be the most prevalent of the limb-girdle muscular dystrophies on the West Coast due to different ethnic backgrounds. The prevalence is maybe 7 per million, somewhere in that ballpark. And again, it makes up 10 to 15% of the limb-girdle muscular dystrophies. As I mentioned earlier, you can present with a predominantly proximal pattern of weakness or a predominantly distal pattern of weakness. But in truth, most patients have a mix, and it's a proximo-distal pattern. So respiratory involvement is prevalent in the Disperalenopathies, and about half of patients will have abnormal testing if you just test everybody. And as people move further in their disease, they will have more prominent pulmonary involvement. And about 10 to 20% will likely need some form of respiratory support, perhaps non-invasive ventilation, late in the course at night. Cardiac involvement, though, is quite uncommon in Disperalenopathies. So just to summarize, the first two of the limb-girdle muscular dystrophies, the calpainopathies and Disperalenopathies, did not have prominent cardiac involvement. The sarcoglycanopathies, so LGMD R3 through 6, though, are different. There may be 5 to 10% of the limb-girdle muscular dystrophies. Generally, onset is younger, so it'll be in the first decade, so the single digits. There are patients who are more affected, which is a Duchenne muscular dystrophy-like phenotype. And then there are patients who have a much milder onset later. It is important, though, to note that they can have heart rhythm abnormalities or develop a cardiomyopathy. This is less common in the alpha-sarcoglycan patients, but it is still possible in alpha-sarcoglycan patients. And importantly, also, you may need respiratory support later in the sarcoglycanopathies. FKRP, or Fukutin-related protein, LGMD R9 or 2I, is another one of the limb-girdle muscular dystrophies for which you do have to think about cardiac and respiratory involvement. These make up maybe 7 to 10% of all limb-girdle muscular dystrophies. It's more common in those of Northern European ancestry. There are forms as early as young infants, and then there are also those that have onset sort of in the single digits, teens, and 20s. Cardiac dysfunction is not uncommon, and so it's important that cardiacism is monitored in patients with FKRP-related disease. And a dilated cardiomyopathy can be seen in, as it says there, 30 to 80% of patients. So roughly half of patients will develop a cardiomyopathy that needs treatment. Respiratory involvement is also common. And so patients will need nocturnal or daytime non-invasive ventilation in maybe a third of patients. It's also important to note that the cardiac and respiratory involvement in FKRP-related disease sometimes is more prevalent than the skeletal muscle involvement. In other words, more prevalent and more severe than the weakness that the patients have. The next of the muscular dystrophies, the limb-girdle muscular dystrophies, is Anoctamin 5, LGMD R12 or 2L. This makes up 5 to 10%, and you'll see I noted here, of diagnosed limb-girdle muscular dystrophies. Interestingly, when you look at genetic data, because this is a later onset limb-girdle muscular dystrophy, it may actually be the most common of the limb-girdle muscular dystrophies. However, many of the patients that have the genetic change have not manifested disease until their 30s or 40s or later. So these patients can present with a proximal predominant pattern. As you can see in the picture, biceps can be weak, and also the quadriceps can be weak in the hamstrings. But it also can have distal involvement where patients have difficulty standing on their toes. Women tend to be less affected than men, and there is not significant respiratory involvement in this. There is, though, an increased risk of cardiac arrhythmias. Generally, these are benign, but it's worth making sure that you follow patients to assure that they don't have significant cardiac involvement. The collagen 6 related disorders, LGMD D5, those are dominantly inherited. They make up maybe 5 to 10% of the limb-girdle muscular dystrophies. There is a milder form, so non-infantile, called Bethlem. And then there is the very early onset Ulrich, much more severe. Pulmonary involvement is much more common in collagen 6 disorders. And that is especially true the earlier the onset of disease in patients with collagen 6 related disorders. As you can see on the bottom charts there, these are scatter plots with lines through them that show over time what the pulmonary function is. And on the left-hand side, you can see Bethlem myopathy. So that is the milder form with later onset. Those patients tend to remain with relatively good respiratory function throughout life. Now, there are some that do have respiratory involvement that needs assistance, but in general, they do better over life. Whereas if you look on the far right, and that's the very early onset infantile form, and it is 50% of those by age 11 years need non-invasive ventilation to help them breathe at night and sometimes during the day. So this really depends on how early the onset is and how long the disease has progressed. LGMD D1, which is due to DNA JB6, this maybe makes up 2 to 3% of LGMD. It's maybe 1 to 2 per million. Onset is later in the third, so the 20s to the 40s, and patients do become wheelchair dependent. This does not have very significant cardiac or respiratory involvement. There can be some respiratory involvement earlier with earlier disease onset, but they don't necessarily have to have respiratory involvement, and it's probably the minority that do. And there's also no significant cardiac involvement. On the other hand, this is one of the limb-girdle muscular dystrophies that is no longer in the new nomenclature, but it still is a limb-girdle muscular dystrophy, and that is LGMD 1B, which is due to mutations in gene for lamin-AC. This maybe makes up 2 to 3% of patients that have limb-girdle muscular dystrophy. It can have very early onset to onset in the teens and 20s. Importantly, there's very frequent cardiac involvement in this disorder. And you'll see it's written there 50 to 70%, and that can happen early in disease, even in the first decade of life. These patients generally have arrhythmias. They can get a dilated or restricted cardiomyopathy, but the major issue is their arrhythmias. Infrequently, they will develop respiratory involvement, but cardiac involvement can be early and can be severe, but it can be treated. So the next topic is, so why do patients with LGMD get cardiac and respiratory involvement? And for some of you, it may be apparent, but we'll just briefly talk through it. And the answer is that there are 3 main types of muscle. There are skeletal muscle, cardiac muscle, and smooth muscle. And there are 640 skeletal muscles, and you can see on the diagram that most of the strength issues that you'll have are related to skeletal muscle. And so when we talk about skeletal muscle, this is generally in the limb-girdle muscular dystrophies, proximal more than distal. The lower extremities more affected than the upper extremities. And what happens is that there is fibrous and fatty replacement of muscles over time. And when you look on the diagrams on the right, these are MRI pictures of patients that have a limb-girdle muscular dystrophy. And in some cases, in the top, you'll see the arrows pointing at, these are the muscles that are along the spine in the lower spine. So these are the paraspinous muscles, and they should be completely dark, but those small circles that are being pointed to are almost completely fatty and fibrous replaced. If you move down below, this is actually a cross-sectional view of a patient with LGMD2L or R12 or anoctamin 5 who has pretty severe involvement. And these are cross-sectional views through the thigh. And what is important on this is that this gentleman is still walking, and you'll see the dark component, and I'll go ahead and point to that here and here. And those dark components are the muscle, and the rest of the thigh musculature is mostly fatty and fibrous replaced. And then finally in the bottom, that's a picture of the calf, and the anterior portion of the calf here and here, the muscle is spared, but there is significant involvement of the posterior aspect of the calf. And of course, with skeletal muscle involvement, you can have weakness, exercise intolerance, it changes your gait. And as I like to say, it makes it more difficult to move against gravity, which means that stairs and chairs and getting up from the floor are much more challenging. Now, respiratory muscle involvement also occurs, and respiratory muscle is skeletal muscle, but we think of it slightly differently. And again, I will go ahead and point out, if you see on the left-sided picture, and there, and there, these are the diaphragm in someone that is unaffected with muscular dystrophy. And then I'm also going to point out, maybe a little harder to see, but there are strips of muscle here that are the intercostal muscles that also help move the chest wall in and out. However, in a patient with a limb-girdle muscular dystrophy, there can be significant, as we see over here, where the asterisks are, there is partial fatty and fibrous replacement, and then significant thinning of the diaphragm. And then it's very difficult to see, but you can maybe make it out. They're just very thin strips of muscle for the intercostal muscles. And thus, patients can have much more difficulty with breathing. And that's the skeletal muscle involvement that is respiratory muscle. And then finally, we have cardiac muscle involvement, and that can be in several forms. On the left-hand side is a picture of a heart that has what's called a hypertrophic cardiomyopathy. And so there's excessive amount of muscle tissue in the heart, which makes it more difficult to move that heart muscle, which actually weakens the heart. In the middle, it's normal. And on the right, you can see it's quite dilated. So the wall at the periphery of the heart, which again, you can see here, is just very, very thin and stretched out, and it has very little strength left. And then on the right-hand side, it just shows that there is significant involvement of the heart in a dilated cardiomyopathy. But what are the early signs that you should be looking out for as to whether or not you have heart and/or lung involvement? So in terms of cardiac involvement, there are several different things that can happen. You can have on the top funny heartbeats or a racing heart, or occasionally a very slow heart. So those are arrhythmogenic disorders. You can also have lightheadedness or passing out, and that can be from the heart not pumping quickly enough and you get hypotensive. And then if the heart just gradually doesn't work as well, you have more trouble doing activities, more fatigue, you can get shortness of breath. You can actually get swelling in your legs and ankles because the heart tends to not pump as well and the fluid backs up. In terms of respiratory involvement, I do like to tell people when I see them that it's important that you know that you can take a lung out of anybody that has no other disease. And so that's half of their lung capacity, and they will not be short of breath. They may not run wind sprints, but it's important to know you can have significant loss of respiratory capacity and still not feel short of breath, and yet it may be significant. So early signs you should look for, again, are exercise intolerance, fatigue, decreased cognitive function and memory, and that's probably because of issues of retaining CO2, and then, of course, shortness of breath. And then, as probably will be discussed, sleep troubles. And so patients that have morning headaches, where their sleep does not leave them refreshed, where they have excessive daytime sleepiness, or they find they have to prop themselves up to sleep well, that is important as an early sign of respiratory insufficiency or that your respiratory muscles are being affected. There is a care guideline that was published, and there are many guidelines that have been published previously for other disorders like Duchenne, spinal muscular atrophy, and ALS. And in 2014, so now that's 7 years ago, there was a guideline published for treatment of the limb-girdle muscular dystrophies. And there was not much data at that time. And so therefore, simply the guidelines stated that for respiratory, that unless you had LGMD 2B or LGMD 2L, then you should have pulmonary function testing and or a pulmonary referral. And then in terms of the frequency of evaluations, it was suggested for 2 of the disorders, LGMD 2I or R9, it should be annually. And then of course, if initially you were abnormal, then your follow-up would be dictated by the pulmonologist. On the other hand, if you were initially normal, it probably should be that you would be reevaluated every 3 to 5 years, or if you have symptoms. And then in cardiac, it was if you had LGMD 2A, 2B, or 2L, you probably did not need a cardiac evaluation unless you had symptoms. But all other limb-girdle muscular dystrophies should have an EKG, an echo or MRI, and then they should have some sort of rhythm evaluation. And then there, again, was not enough published data to suggest what the frequency evaluation should be, but generally that'll be dictated by the cardiologist if you have symptoms or abnormalities on testing. And if you're initially normal, then you can be reevaluated every 3 to 5 years. So let's talk about what is optimal care for the limb-girdle muscular dystrophies. This is multidisciplinary care. As you'll see in this diagram around the outside are therapy services that are integral to the health of the patient, of the person that's in the middle. And then also you'll see in that inner ring that there are certain providers that can be helpful, and key amongst those, and highlighted, are pulmonologist and then cardiologist. This is what our multidisciplinary team looks like. For our clinic, we have the resources that are available on the left there. We also have collaborative agreements with those on the right. And you'll see it says neuromuscular pulmonologist. And that's very important because most of you do not have any problems with your lungs. You have a problem with the muscles that move your lungs. And when that's the case, then you don't really need somebody that understands COPD or asthma. You need somebody that understands the bellow movements of the lungs, and that's a neuromuscular pulmonologist. We also have a neuromuscular sleep specialist who fully understands that. And then cardiologist, it's interesting that you really need some cardiology specialists that are that specialize in particular areas. So there are people that understand heart failure due to genetic muscle disease, and those are cardiomyologists. And then there are also people that are electrophysiology specialists, so they understand the rhythm abnormalities of the heart. And so depending on which your abnormality is, you may need one or the other, because most cardiologists specialize in one or the other. In terms of assessments, in our clinic, we'll do an initial set of pulmonary function tests at our first visit. And then we'll make sure that we do pulmonary function tests in the upright and in the supine position. And the main reason for the supine position is that the diaphragm is a dome-shaped muscle. And if you see my hands, and so that means that when you're sitting or standing, gravity helps you out. But when you become supine, for example, for sleep, three things happen. You lose gravity's help, and no matter how thick or thin you are, you actually still have to push against abdominal contents. And then during deep sleep and dream sleep, your muscles are quite relaxed, or dream sleep, which is rapid eye movement sleep, your eyes move and your diaphragm moves, but the other muscles, the chest wall muscles, are no longer helping out. And so you can have difficulty in that supine position with your breathing that may not show up when you're upright and awake. In terms of sleep medicine, we will refer people if they have sleepiness during the day, they have frequent naps, they have morning headaches, and they have leg edema, or if their pulmonary function testing is less than 70% predicted. It is important that the right sleep study is done, and generally that's going to be a sleep study that includes a look at CO2 monitoring, and then you want to make sure that you do not have somebody, if you have significant respiratory weakness, that tries to put you on CPAP, because it just won't work well. You'll need BiPAP or some other type of variable pressure device. I'm not going to spend too much time on this slide, but it's important that you have a neuromuscular pulmonologist. As your pulmonary function is more challenged, you'll need help with clearing of secretions. It's important to learn how to do the clearing of secretions. If you don't have a sleep study and you have significant respiratory insufficiency, you may be able to go on non-invasive ventilation at night and feel much better. And I'm going to focus in the upper right, which says up-to-date vaccinations are very important. And that does include pneumonia vaccine, influenza vaccine, and in today's world, it definitely includes COVID-19 vaccination. These are just some pulmonary assessments that are done. So forced vital capacity, maximal inspiratory and maximal expiratory forces. There is a SNP, so that is a sniff inspiratory pressure. And these are all helpful for your neuromuscular pulmonologist in managing your disease. Again, there are different ways you can look at lung function. So there is lung size and ventilatory capacity, and these are the measurements that do that. There's the muscle output, which mostly has to do with these maximal inspiratory and maximal expiratory pressures, and then the sniff nasal inspiratory pressure. And then you can look at gas exchange by doing a pulse ox or looking at CO2 monitoring. In terms of cardiac assessments, you will hear quite a bit about how that's optimally done in the subsequent lecture, but our initial evaluation is an examination, an EKG, some sort of cardiac imaging, whether that be echo, MRI, or other, and then some form of rhythm evaluation, whether that be Holter or ZO, etc. And then our subsequent evaluations, if you're normal, we'll reevaluate you in 3 to 5 years. And then if you have involvement, our cardiomyologist or rhythm specialist will make sure they follow you. So I'm going to end with appropriate care does involve a multidisciplinary approach. And amongst those, you can see on your screen, definitely it includes a cardiologist that understands muscle of the heart, and then a pulmonologist that understands, again, the muscles that move the lungs, because your lungs are probably normal. It's just that you need somebody that understands how those bellows work and how to optimally manage your symptoms associated with that. So I'm going to say thank you very much for attending this, and hopefully this was informative. And as you move forward, not only will there be care for your skeletal muscle disease, but make sure you take care of your heart and your lungs and the muscles that move those two organs. Thank you very much.
Thank you, Carol, for that lovely introduction. And thank you, Dr. Wicklund, for a wonderful introductory talk. I hope to expand a little bit on some of the respiratory issues that arise in limb-girdle muscular dystrophies. So why don't we get started? So first, just a quick outline of what we're going to talk about. We need to talk about basic respiratory muscle function to understand where problems arise. Then we'll talk about pulmonary function tests, how we measure respiratory muscle function. We'll talk then about what we do to deal with those issues in respiratory management. And then I just want to spend a couple of minutes on talking about COVID and neuromuscular disease. So let's talk about basic respiratory muscle function. So breathing takes muscles. The lungs themselves actually don't have much in the way of muscles, certainly not skeletal muscle, which are usually involved in the limb-girdle muscular dystrophies. Breathing in is the most active part of breathing in terms of muscle demands. Breathing in, or inspiration or inhalation, is done mostly by use of the diaphragm, the major muscle of breathing, which sits at the bottom of the lungs and separates the chest from the abdomen. When we want to deeply inhale, we also use the external intercostal muscles. So these are the inspiratory intercostal muscles here in pink purple, and then also accessory muscles that pull the chest upward and outward. So these are the sternocleidomastoids and the scalenes. We usually think of exhalation or expiration, breathing out, as passive. The inspiratory muscles relax, the chest collapses, and air rushes out of the lungs. That's true if we're just sitting and breathing normally. But if we want to do anything more than that, we need muscles of exhalation. And so if we want to talk, if we want to cough, if we want to laugh, if we want to shout to a friend, if we want to run or move quickly, then we have to use muscles of expiration. These are the internal intercostal muscles here in this light green. They sit between the ribs, and also the abdominal muscles that can squeeze the belly so that the chest is compressed upward and air comes out. So normal breathing is a balance between the tendency of the lungs and the airways to collapse or to shrink down, and the tendency of the respiratory muscles and the chest wall to expand. These are all controlled, of course, by the brain, but the general idea is that we maintain some sort of lung volume because of these competing tendencies for collapse and expansion. When we lose our respiratory muscles, we no longer have as much ability to expand, and so the whole respiratory system tends toward collapse and we get lower lung volumes. Now, it's important to remember, as Dr. Wicklund so eloquently pointed out, that not all limb-girdle muscular dystrophies are made equally. Not all of them have respiratory involvement or the same respiratory problems. We can see changes in respiratory function based on position, and we'll talk a little bit more about that soon. There are definitely differences between awake respiratory function and asleep respiratory function. And then it's important to note that ambulatory status does not always mean that lung function is normal. So there are patients who can be ambulatory, but who have relatively decreased lung function that can impact their lives. So what are some symptoms of respiratory muscle weakness? Oftentimes we don't see much. This can be pretty silent. So we can have no symptoms if the impact is mild, or even if it's severe but has been slowly progressive. So losing lung function incrementally over time can make it very hard to feel the changes. Certainly, if there are other muscle issues going on, then respiratory dysfunction can be obscured by that. So for instance, being non-ambulatory makes it less likely to require on a daily basis large lung capacity for things like exercise in terms of at least running and for other functions. So it can be obscured by other muscle dysfunction. If you have symptoms, often what we see is an impaired cough function, which manifests itself as frequent, recurrent, or prolonged respiratory infections. We can see disordered breathing during sleep because muscle function declines in everybody during sleep, and we rely mainly on the diaphragm alone and not all the other muscles of breathing. So we can see snoring or sweating during sleep, which is a sign of increased work of breathing. We can see restless sleep because breathing is disrupting our sleep. We can see frequent awakenings for the same reason. Morning headaches are a big symptom that I look for because it signals that breathing may not be normal during sleep, which causes oxygen to fall, carbon dioxide to rise. That can cause headaches. And then in kids, I often look for impaired school function. In adults, we talk about impaired work function and daytime fatigue. We can also see swallow dysfunction, which relies a little bit on the muscles of respiration, but also on other muscles in the head and neck region. So we can see coughing and choking with eating or drinking, unexplained respiratory symptoms or infections. In infants and children, I often see food or liquid refusal because they know something's wrong, they're just trying to protect themselves. And then again, in infant and children, we can see low weight or poor weight gain. So let's talk about how we measure these things. So first things first, one of the best pulmonary function tests that I have over time is history. So in infants and young children, we talk about the pregnancy. How was fetal movement? If there wasn't a lot of movement, then that suggests muscle weakness, which suggests that breathing may be impaired. What was the birth history like? Was respiratory support needed? Was nutritional support needed? As time goes on, we look for respiratory illnesses, exercise intolerance, secretion management. So is the head and neck region functioning well? Is there risk for aspiration? And then I look a lot for sleep dysfunction and swallow dysfunction. The next best test is a physical exam. So what does the patient look like when they're breathing? I put my patients in different positions to test different respiratory muscles. And if we can, we put them in positions of stress, whether that's exercise or just positional changes. We measure oxygen levels, carbon dioxide levels when we can with a blood gas, and then we get to pulmonary function tests. I've put other tests in parentheses here because they also measure to one degree or another respiratory muscle function. Those include sleep studies, swallow studies, chest x-rays, and spine x-rays. So I have 4 pulmonary function tests that I really look at. The first one is the forced vital capacity, which essentially measures how much air can I exhale after filling my lungs completely. So whatever my lung capacity is, I have to be able to take it in order to blow it out. Next, I look at peak cough flow, which simply measures how fast does air come out when I cough. And then I try to isolate specific respiratory muscles with the last 2 tests, the maximal expiratory and inspiratory pressures. Maximal expiratory pressures does exactly what it says. It measures how hard can I exhale. So the patient will blow against a closed valve that will measure the pressure difference across that valve. And the same is for inspiratory pressure. You suck in against a closed valve and measure how much pressure is generated. Those 2 tests isolate expiratory muscles and inspiratory muscles, so I can see which, if either or both of those muscle groups are impacted. Vital capacity requires both that you be able to inhale and exhale forcefully, so it doesn't really tell me which group of muscles is involved. And same thing with peak cough flow. Let's spend a minute talking about sleep studies. This is important. So I'm not going to go over all the different things that we measure in a sleep study, but the important ones for respiratory function are nasal and or oral airflow. Is air moving is the question. Is there actually movement of air? Am I breathing? And then a similar measurement is nasal pressure, which asks essentially, is there obstruction to airflow? Is the problem that I can't get air in because there's something in the upper airway, like tonsils or adenoids, for instance? And then we also look at chest and abdominal wall movement to see, is this a normal pattern, or is there an abnormal pattern suggesting respiratory muscle weakness? So we're really asking, are the muscles working as they should based on each sleep stage? We measure oxygen, and in neuromuscular disease, we always want to measure carbon dioxide. So are these changing abnormally during sleep, or are they not? And then we also look at heart rhythm just to make sure that we're not seeing any effects on the heart from breathing issues. And then, of course, in a sleep study, we can also titrate respiratory support. So if you're already using support at night, we can make adjustments to it to see if this makes your breathing even better. So a sleep study will look for apnea, which is cessation of breathing, hypopnea, which is shallower breathing than expected, rapid shallow breathing. So are you breathing fast because you can't take a big deep breath? That's a sign of respiratory muscle weakness potentially. We look for oxygen levels, low oxygen levels, high carbon dioxide levels, which is called hypoventilation. We look at the work of breathing and the breathing pattern and how breathing changes during each stage of sleep. It's important to note that not all sleep labs and sleep studies are created equally. For neuromuscular disease, we really insist on having a carbon dioxide measurement, which is relatively rare in adult labs and less rare in pediatric labs. And then the sleep lab can't just measure carbon dioxide levels. They also need to know neuromuscular disease, especially if they're going to start someone on a respiratory assistance device like a BiPAP machine. They need to know the patterns of respiratory muscle weakness and that this is not simple obstructive sleep apnea. A lot of people ask me, well, I've heard about home sleep studies. Can I do my sleep study at home? And the answer, unfortunately, right now is no, because those studies are designed to look for classic obstructive sleep apnea, for snoring, things like that. And they're not designed to look for respiratory muscle issues that we see in neuromuscular disease. So unfortunately, our sleep studies currently have to be done in the lab. Let's talk about what we do about all these problems. So before we talk about what we do, I suppose we should talk about why we do them. What are the goals of respiratory care? Number one is improving quality of life. That's nice, but how do we do it? Well, I want to reduce the work of breathing so that that energy is preserved and can be spent elsewhere. For the kids that I deal with, that means going to school, learning, playing. For adults, that may mean working, enjoying their weekend, going on vacations. I want to preserve your energy for life instead of using it excessively on breathing. We do that by improving oxygen and carbon dioxide levels and by improving sleep quality. We spend, or we're supposed to spend, about a third of our lives asleep, and yet we often neglect that. Sleep is incredibly important to our daily function. So if we sleep well, our daytime function improves. And then I also want to facilitate care at home. So I want my patients to have the resources that they need to reduce hospitalizations, intubations, critical care, tracheostomy, etc. And I also want people to have a plan. So I want to plan for procedures and illnesses so that we're not frantic and we're not scrambling. The other way to think about goals of respiratory care is to remind ourselves of our tendency to collapse when we lose our respiratory muscles. And my goal is to restore that balance with mechanical treatments. So mechanical support really has four main objects. Number one is to clear the airways and prevent infection by improving cough function. Number two is to help breathing during sleep. Number three is to help breathing during the day if that's needed. And number four is to manage breathing during infection and other stresses like procedures and hospitalizations. And of course, we can't forget the other systems and issues that may impact respiratory function, including but not limited to our nutritional status, cardiac function, our gastrointestinal tract function, orthopedic issues, especially spine issues like scoliosis and kyphosis, endocrine disorders that may affect bone health because bones are part of the respiratory system of the chest wall, and many, many more. So let's talk about each of those 4 goals of mechanical support. So goal number 1 is to improve cough function. We have to remember that in neuromuscular disease, a weak cough means that we might be able to mobilize our secretions, but we can't expel them. We can't actually get them all the way out. So cough function is really important. In other respiratory diseases that you may see lung doctors talk about, we talk about mobilization of secretions, and that's not the issue here. It's really expulsion of secretions. So cough augmentation is priority number 1. And the way that we achieve this is with these devices that you see pictured below. Those are what we call cough assist machines. They should actually be called mechanical insufflation, exsufflation devices, but that's too long. So we call them cough assist, which is actually the trade name of this machine here. And what these devices do is relatively simple. They first give a positive inflation pressure, so big breath in, and then it flips and gives a negative expiratory pressure, just like a cough, right? When you cough, you take a deep breath in, and then you blow out. And then it pauses until the next cough cycle. So a cough assist or a mechanical insufflation exsufflation device can be used through any interface. It can be done through a mask, which you see both with the infant on the left and the woman in the middle right. You can use it through a mouthpiece, like the young man on the middle left, who's managing his own cough assist device. And you can do it through a tracheostomy tube, like the young man on the right, or even an endotracheal tube. So if you're intubated with a breathing tube in the hospital, it can still be done. So there's no reason, if it's needed, to not use a cough assist machine. And here's just a quick example that was published several years ago in medical literature. So this is a child with neuromuscular disease, but this applies to adults as well. You can see in the right upper portion of the lung, there is a whiteout, which suggests pneumonia or mucus. And after several sessions of cough assist, after several sessions of cough assist, this right upper lobe of the lung is now cleared. It's black, which signifies air. So this can be very, very effective, even in the acute setting, for removing mucus and improving work of breathing and respiratory function. So when do we do this? When do we start using cough assist? So in some patients, we use it preventively because we've identified breathing weakness before infections occur, or especially in babies, I use it when I see the chest wall developing abnormally, which signifies respiratory muscle dysfunction. In young children or young adults and adults, we can justify using it based on lung function. So if the vital capacity is less than 50% of expected, if the cough is weak, or if the expiratory pressure, the ability to push out, is weakened, then we should use a cough assist device. And then we can certainly be reactive as well. So even if the numbers are normal, but we have neuromuscular disease, if we see recurrent, frequent, or persistent chest infections, that's a good sign that we should be doing something about cough function. Okay, let's talk about our second mechanical goal, which is support breathing during sleep. So we definitely want to treat sleep apnea and or hypoventilation if it's present. We want to allow respiratory muscles to rest, which means that we have to synchronize the breathing with the machine, and we want to expand the chest because that allows for better air entry and exit. And then, of course, the overlying goal of all this is to improve sleep quality so that quality of life is improved. So support during sleep in neuromuscular disease is different than the common obstructive sleep apnea. The most work that we do during breathing is inhalation. So we have to support that work, inhalation, for neuromuscular disease. And that means BiPAP. And I'll show you a graphic of what that looks like in a second. oxygen and CPAP are not appropriate for neuromuscular disease. It has to be BiPAP. So when do we start BiPAP? Well, just like before, we can start it for subjective reasons or for objective reasons. So for subjective reasons, neonatal respiratory failure or respiratory failure in anybody really can lead us to use BiPAP. If there's poor growth or inability to maintain weight, that may be a sign that calories are being burned excessively during sleep. So after looking into that further, we may use BiPAP. Frequent respiratory hospitalizations or recurrent pneumonias, persistent coughing may be an indication to use BiPAP as well. Objectively, we can use pulmonary function tests to justify BiPAP. So if the vital capacity is less than 50% of expected, if the inspiratory pressure, the inability to inhale, is reduced, less than 60 centimeters of water pressure, or if the oxygen level is persistently below 95%, or the CO2 level is persistently just a little bit elevated at 45 millimeters of mercury, then we can use BiPAP. And of course, if a sleep study shows low oxygen, high CO2, or other signs of respiratory muscle weakness, we should use BiPAP. It's important to note that most insurance guidelines do not require a sleep study if you have a neuromuscular disease diagnosis and you meet any one of these first three categories. And you don't need a sleep study to start BiPAP. Your doctor may have to jump through some hoops, but that's our job. Okay, so let's look at what CPAP is. So here we have a graph of pressure over time. CPAP provides one continuous pressure. You can see it's above the 0 line, so there's some pressure, but it's just continuous over time. That's what the C stands for, is continuous positive airway pressure. There's no additional support when your diaphragm is working, when you're trying to breathe in. On the other hand, if we look at BiPAP, we have an expiratory pressure, which is oftentimes at the same level as CPAP. And then when you breathe in, we get another higher pressure, which is called our inspiratory pressure to help the diaphragm. And then it comes back down to our expiratory pressure when you exhale, and it goes back and forth. And that we should technically call BiPAP, or biphasic, two pressures, positive airway pressure. Here's the key. Don't use CPAP. Okay, let's talk about respiratory support during the day. This does not happen to a lot of people or for a lot of people with limb-girdle muscular dystrophies, but some do need it, and so we should talk about it. So people may need support during the day when their vital capacity becomes very, very low, what we call severe restriction. Usually we define that as less than 20% predicted. If they have daytime elevations in carbon dioxide, so now the hypoventilation is happening even awake, or if there's daytime fatigue or shortness of breath. Some of my patients report that they have noticed they're using cough assist more and more during the day because they really just feel like they need that bigger breath. Well, there's a different way of doing that. We can use positive pressure during the day instead of coughing during the day. And then most recently, my patients have taught me that what they really want is speech augmentation or volume support. They want to be able to be heard. Before we stopped going to bars, and hopefully we can start going again soon, my patients told me their friends couldn't hear them over the noise of a restaurant or a bar, and they wanted to be heard. And so the way to do that is to take a bigger breath, right? If we want to be heard, we increase our volume, so we take a bigger breath and then speak. People with respiratory muscle weakness can't do that. So this is a way, daytime positive pressure support is a way to do that. Some of my patients also report that it's hard to eat because they're short of breath, and coordinating chewing and breathing and swallowing has been very difficult. So we can support breathing during meals in a specific way so that eating is a little bit easier. So we can do this through any number of ways. The interface is actually important. On the bottom left here, you see a nasal mask being used. You'll notice that the mouth is free, and that's very important, especially if we're trying to augment speech and swallowing. In the middle picture, you see a young man using what we call sip and puff ventilation or mouthpiece ventilation. This device is attached to the ventilator on the back of the chair through this rigid hose that's adjustable. It does not have to sit in his mouth all the time. It sits close to his mouth. And when he needs it, he just turns his head and takes a breath. This young man has a tracheostomy tube. So that's a consistent way of providing respiratory support. And then I also listed full face mask here. That is not something that I would recommend even during sleep because it covers the nose and the mouth, and that limits speech, limits the ability to get help if needed or ask for assistance if needed. So full face mask is actually not recommended for daytime support. The last goal of mechanical treatments is to manage breathing during emergencies. And by emergencies, I don't just mean critical illness. I also mean needing anesthesia or anything changing from our baseline. So it's important to remember that weak respiratory muscles get overloaded and weaker with any kind of stressor, especially pneumonia, bronchitis. Just fever can make muscles work harder. Anesthesia, surgery, dehydration makes our muscles work harder. Heart disease can make our breathing muscles work harder, and many other causes. The point is to use BiPAP early in an illness and after surgery. And in my practice, it's okay to do those things at home around the clock if you already have them and you feel comfortable with that. That doesn't mean you have to stay home, but it means you can if you're comfortable with it. Again, oxygen and CPAP are not appropriate for acute care or for chronic care. Cough assist should be used liberally to improve oxygen saturations. The reason that someone with respiratory muscle weakness may have low oxygen is because they may have some mucus stuck in their chest. The only way to get that out is by augmenting the cough. And then most importantly, you have to have a plan. So the first step is bringing the respiratory equipment to any ER visit and to all surgeries so that the team that takes care of you has the resources that you have available to you. It's also important to note that many emergency departments are not necessarily familiar with respiratory support, especially cough assist. So one, may not have a device, and two, may not be familiar with using it, even if they do have one of those. You may be the expert, you or your family may be the expert. And so it's important for you to bring your devices to your care. So let's talk a little bit about a different kind of emergency, or a stressor really, and that's anesthesia and surgical care. So for planned procedures, it's important that you see your pulmonary team prior to surgery to get updated lung function tests to talk about a specific plan to manage your breathing during and after surgery and what recovery might be looking like. Some risk factors for inability to extubate or inability to remove the breathing tube after surgery include low lung function, so lung volumes under 50% predicted, but especially under 30% predicted. And then isolated respiratory muscle weakness, so either a MIP or a MEP of less than 60. And then if your cough is weak, it's also a potential problem because when you have a breathing tube, you're sedated, so you can't cough very well anyway. So if your cough is weak, it may be hard to get the breathing tube out. My recommendation, especially for procedures that are unrelated to respiratory function, is to not take the breathing tube out unless the lungs are healthy. They're back to their baseline, which means to a doctor, no extra oxygen is needed through ventilatory support. And if possible, a chest x-ray that looks clear. So there's no pneumonia or lung collapse or excess mucus in the chest, or excess fluid in the chest in the case of heart disease. I always recommend extubating directly to BiPAP support. So there's still some respiratory muscle support. And I also recommend using cough assist frequently to continue mobilizing and expelling normal secretions. So when we talk about respiratory support during stressors or acute events, it's important to note that short-term issues, like let's say pneumonia, can result in long-term issues. So a short-term problem like pneumonia, can end up requiring a long-term plan because they're not necessarily distinct issues. Big decisions are best made outside of the acute setting. So it's important to talk to your team, and your team may be your doctors, but it most certainly is your family or those close to you who would help make decisions. You need to talk to them about what you want. What's my code status? What happens if? What happens then? Talk to them about advanced directives, whether or not you are thinking that tracheostomy is okay for you or not. And I'd like you to think that a tracheostomy is not the end of the world. It's simply a tool. If it fits into your goals, then that's a tool you should consider using. If it doesn't fit into your goals, then it isn't a tool you should consider using. The most important message here is that the decisions you make are right for you. I'm only your advisor, your consultant. I can help you reach information, but I can't make decisions for you. And once you make a decision, then I support it 100%. Okay, let's talk just a second about COVID. So like any other respiratory infection, COVID causes respiratory stress, and as we just talked about, that can be very problematic. However, this virus creates a lot more inflammation and damage than most other viruses. And we know that people with quote unquote normal muscles become debilitated, weak, unable to walk, unable to breathe without significant assistance. And so we're very concerned that people with underlying muscle weakness and respiratory disease can be even more adversely affected and may end up even more debilitated from a breathing standpoint than those who have quote unquote normal muscles. So what have we done in the past year and a half or so? Well, we've worn masks, we've distanced ourselves socially, we've washed our hands maybe more and more thoroughly than ever before, but that comes with real and lasting effects. I don't think that's the solution, and it's not sustainable. So what do? Well, the answer is to vaccinate. Vaccines work, they're safe. They currently protect against the Delta variant, and we know this because over 99% of hospitalizations and deaths from the Delta variant are in unvaccinated people. So vaccination is really the most important step we can take to protect ourselves and our communities. And if you can't get vaccinated, please be careful, wear a mask, and isolate yourself if you're sick, even if you don't think it's COVID. Okay, thank you very much for your time.
Thank you guys so much for this wonderful presentation. I just want to say thank you from all of the Limb-Girdle community. We have a couple of questions we'd like to ask just to follow up on some of the presentations that we just found them fascinating. One of the things is we had a question about how do people find a neuromuscular pulmonologist?
That is a fantastic question. Your best bet is probably to talk to your neurologist, who should have some contacts in the community or in their institution.
Yeah, okay. Kathryn, I'll chime in and I'll say it probably goes both ways. It's important for that neuromuscular pulmonologist to know that there are going to be patients coming, for example, from the MDA clinic or some other neuromuscular center. And it's important for the neuromuscular providers to know that their pulmonologist understands not just the lungs, but also, more importantly, the bellows that move the lungs.
Got it. That's a good advice. One of the things we also wanted to ask, is it something that potentially patients, if they can't travel to a place where that's provided, do you think that's something that could happen via telehealth at this point?
So yes, we've done a fair amount of telehealth with our established patients. I think what you lose in telehealth is the pulmonary function test. So that makes it a little bit challenging. But there are ways to contend with that. New patients, I think, are more difficult because we really need baseline respiratory function.
Okay, I agree with that. On the issue of supine testing with PFTs, what would a patient
need to do to request that? I see a lot of patients saying that they go to get their PFT, and unfortunately, they are not being given the option to do any of it lying down. What would you recommend if a patient is dealing with that issue? And I think a lot of our patients are over the country.
Yeah, so I think it depends on what the issue is. Most pulmonary function labs are in small rooms, so it's just hard to get a bed in there to lay down on. If you're in a power chair, you can just do the testing reclined. That's often what I do in my clinic. If you're seeing a neuromuscular pulmonologist, though, they should have the capability or the creativity to do this.
Yeah. Dr. Wicklund, what's your thought?
Yeah, I was going to ask Oren. So do you find that there are certain tests that are easier or harder, or for, just all throughout the country? Let's say that they're not a neuromuscular pulmonologist. Is there something they could do upright and supine that would be relatively easy, even if it was just handheld spirometry?
Yeah, you're right, Matt. That's a great point. Handheld spirometry is probably the easiest thing to do. So just the vital capacity in the supine position is probably the most important test. I don't think you need to do MIPS and MAPS and peak cough flows supine. So if there's any way to use a portable spirometer or longer tubing on the pneumatac to do it just outside the room instead of in the small PFT lab room, then I think that's worth trying.
Okay. And then why would you only look at the forced vital capacity and not the MIP and MAP?
So forced vital capacity is kind of the culmination of all of the respiratory muscles functioning together. So it's a gross aggregate. It doesn't give you the entire picture, but it gives you a pretty good sense. When we're asking for a supine vital capacity, we're really specifically looking at diaphragm weakness, isolated diaphragm weakness. And so the change in position just with vital capacity will answer that question.
Okay.
So doing the other tests in different positions doesn't necessarily answer the question as clearly as a vital capacity.
Would you recommend, if a patient has a significant decrease in forced vital capacity when lying down, that the patient maybe sleeps propped up?
I would actually change that. I would say they deserve a sleep study because one of the reasons we look at supine vital capacities is to look for diaphragm dysfunction or diaphragm weakness. And remember, during sleep, the diaphragm is the only muscle of breathing that's still functional, at least in REM sleep. And so if it's dysfunctional and we're in REM sleep, there's a high likelihood of having sleep disordered breathing or hypoventilation. So my response to a dysfunctional diaphragm is you need a sleep study, not you should change your position.
Okay. I will say I think there's a lot of fear and panic in this area of heart and lung issues with muscular dystrophy individuals. I think fear, particularly with breathing, even more than heart issues, it's not uncommon. I think in the last couple of years, I've had at least 2 individuals with Limb-Girdle pass away due to breathing issues. When this occurs in our community, it is terrifying because some of them have the same subtypes that others have, and we're finding out that the individual had some issues with breathing that were just underdiagnosed. What can we do to be proactive in this area so we're not in a situation like that?
I think I'll answer this question first, and then Matt, I'm sure you have thoughts on it as well. I think you need to advocate for yourself. You need to get pulmonary function tests, and if you feel that something is amiss, get yourself to a pulmonologist and get into a sleep lab that will diagnose you correctly. So don't leave it up to chance, and take advantage of all the resources you may have and demand more resources if you don't have them.
Yeah, and I'll follow up with what Oren said, and I agree. You may not, depending on where you're located, have somebody that is a neuromuscular pulmonologist. And we're out west here, and there are people that probably, I'm going to get in trouble. There could be an entire state that did not have a neuromuscular pathologist, and it's a big state. And so you may actually be able to get some of your care locally, but you may want to make that extra effort, if you're worried about it, to seek care at a larger neuromuscular center and it may be a once a year visit, but that still will be helpful so that you can get a diagnosis. And I know, again, out here in Colorado, we've reached sort of 11 states, some of which are very big, but not very populous. And we'll have our folks show up maybe once a year so we can reevaluate them. And then we'll also give guidance back to their care providers locally.
That brings up a good point, is that we're geographically dispersed, and yet I sit in a bit of an ivory tower in an academic institution, but we're happy to communicate with local providers and provide that kind of care too. Local providers are really committed to their patients. It's not that they're not committed, it's just that they don't necessarily have all the resources. And so we can share that. We can share those resources and the education that we have with the local provider.
Oh my gosh, what a great point, because I do think that traveling to that specialist for this and then allowing that specialist to communicate back to your local pulmonologist is the way to go. And that's actually how I do my care. And I have been doing it that way for a while. And I have found that to be very effective. The other thing too, I have found is looking for a local DME company that actually understands neuromuscular diseases. So some DME companies will understand it, some won't, and finding if they have a lot of patients that are on ventilation, that is helpful. Last thing I wanted to share is just a word on cough assist. And patients often think, because of the way it's described as a cough assist, that I don't have any lung secretions, I don't have any congestion, why should I use a cough assist? I don't need a cough assist. And so I used to think like that too, but then I noticed when I just used the cough assist every day because the doctor said to do it, even though in my head I was like, I don't need this, but I started using it. And of all the things I noticed, like there was an expansion in my lungs and it felt good. It was stretching out those muscles. And so can you guys talk a little bit about that? Because I have found that my forced vital capacity, when I'm doing it, actually stays pretty constant. And when I haven't done it, guess what? It starts to go down.
So there are a few points that we didn't talk about in the slides. It's not just respiratory muscles, right? You have joints in your chest. All the ribs that connect to the sternum and all the connections of the ribs in your back to the spinal cord, those are all joints. If you don't exercise those joints, they get stiff. It's just like your ankles, just like your wrists, just like your neck. Those will all get stiff and they'll get contracted, and then they won't work very well when you need them to. So keeping those joints loose by doing essentially physical therapy with the cough assist could really help maintain lung function. So I think that's what you're feeling.
Ooh, that's good. That is really good advice. You know, I hope everybody's listening to that. Dr. Wicklund, what would you say about that?
No, I totally agree. It's kind of like if you're not exercising, you're not doing your physical therapy. This is just right, physical therapy or exercise or activity to keep your lungs active and healthy. So it'll work well. And the other point that I think you'll find is when you do cough assist prior to getting ill, you sometimes will not get ill. And so you'll not only feel better, but you'll, instead of having whatever bronchitis once or twice or 3 times a year, all of a sudden you'll go, oh, it's been a whole year. I feel pretty good. Never happened, because you're able to clear out those secretions. So it just got to go that route and try to be diligent. And if you start early, it's also easier to continue. It just becomes part of your daily routine.
Yeah, we all cough every day, no matter what, even when we're well. Some of us need some assistance to do our normal maintenance coughing. So that's what Cough Assist will offer.
Well, that's great advice, guys. Thank you so much for just answering some of these questions. And I mentioned before that maybe in the future we'll do a Q&A with individuals with Limb-Girdle through another webinar. So I would love it if maybe in a few months after the first of the year, we can maybe sit down again and just with the Limb-Girdle community and allow them just to ask a bunch of questions about this. Would you guys be up for that?
Absolutely.
I would love to do that. And I think I might be able to find you a couple of adult pulmonologists as well, who would be terrific resources to feel a little out of place doing adult care, but I'm happy to do it.
We would appreciate that as well. And so thank you guys so much. Great job. And we just are very thankful for you as clinicians to be in here today. Thanks.
Thanks.
Hello, it's great to be with you virtually. I'm Elizabeth McNally. I'm at the Northwestern Medicine, where I direct the Center for Genetic Medicine, and I'm a member of the Bloom Cardiovascular Institute. I am a cardiologist by training, and I take care of lots of muscular dystrophy patients. And so I'm delighted today to talk to you about limb-girdle muscular dystrophy and the heart. Just some of my disclosures. I do work with a number of companies. My grant support is listed, and all of this is unrelated to the content of this talk. So just as an overview, the key take-home points to have today is that only some of the subtypes of limb-girdle muscular dystrophy actually have heart involvement. And so the most important aspect is to know what your genetic subtype is so that we can better predict who is likely to have heart involvement and who needs to see a cardiologist. The type of heart involvement that can occur in the muscular dystrophies and the limb-girdle muscular dystrophies includes cardiomyopathy, sometimes the symptoms of heart failure, which can manifest very differently in people with neuromuscular disease, and then arrhythmias or irregular heart rhythms. And so the two parts of this, the cardiomyopathy and the arrhythmias, are managed a little bit differently, and that's what we'll talk about today. Heart failure is what happens when somebody has symptoms from their heart not functioning normally. And in people with neuromuscular disease, sort of the normal ways we might measure that are difficult to do because if people are non-ambulatory. And so instead we rely much more on biomarkers and imaging, and those are the things we'll talk about today. And then another take-home point is that the multidisciplinary team, including the respiratory management, is a very, very important part of keeping your heart healthy. So let's start at the top, which is that there are a large number of neuromuscular diseases that are genetically defined. And so again, genetics is a key part of this. And this is just a listing of many of the neuromuscular diseases that we know have heart involvement. So we know it's true in Duchenne and Becker muscular dystrophy, but then importantly, we know there are subtypes of limb-girdle dystrophy, notably LGMD 1B or the type 1 dominant LGMDs, and then some subtypes of the recessive LGMDs as well. And then there are other disorders like Friedreich's ataxia, myotonic dystrophies, type 1 and 2, the congenital myopathies, the myofibrillar myopathies, and mitochondrial that can also have cardiac involvement. So most of what we know, actually, we've learned mostly in the setting of Duchenne and Becker muscular dystrophy. And so in some settings, we're actually borrowing from that knowledge and applying it to the limb-girdle dystrophies. So as I mentioned, genetic diagnosis is really a central part of knowing what your cardiac risks are going to be. And so you've probably heard that before. Many of you are very knowledgeable about this, but you have to know what your genetic diagnosis is. And so the mainstay of how we get at that genetic diagnosis for limb-girdle dystrophies is using gene panel sequencing. That usually involves sequencing anywhere from 50 to 100 to 200 genes, sometimes more, where they mostly look at the genes themselves and a little bit of what we call the non-coding region next to it. And then they look for variants which are rare, genetic changes which are rare in the population, and use that to come up with a genetic diagnosis. It's important to recognize a lot of the testing companies are doing this in the absence of having in front of them all your clinical history, because we often send out your DNA samples to these testing companies. And so really it comes down to your doctor knowing your history and looking at those genetic variants that can often best come up with what your real genetic diagnosis is. And I know that can be a little tricky for some of the limb-girdle dystrophies, especially the recessive ones. And so sometimes we do things like looking at all the genes in a person, and that can be done by looking at the exome or genome. For those of you who are younger, occasionally, if both your parents don't have a disorder, we may want to test both of your parents and then you at the same time, and that's called a trio exome. And that helps us get at variants which in combination are present in the child or the offspring that are shared differently in the parents. And so we can often figure things out that way. Structural variation refers to when there's a big deletion in the gene or an insertion in the gene. And some of the next generation sequencing that we use to do gene panel sequencing may not be so great at always detecting certain types of structural variation, although it's gotten quite a bit better at being able to do that. And sometimes what we end up doing is doing a muscle biopsy where we have to look at how genes are expressed in that muscle and do that alongside the DNA information to help interpret what we call these variants of uncertain significance. And then of course, we know about the repeat expansion disorders like myotonic and Friedreich ataxia. And there we have to use different genetic tools to go right at those repeat expansions. And so for limb-girdle dystrophy, gene panel sequencing is the mainstay of what we do, sometimes trio exome, and then sometimes in the context of muscle biopsy information. So a key aspect to appreciate is that we have three major muscle types that are important in humans. We have smooth muscle, which is the muscle that contributes to lining the gut and the arteries. We have cardiac muscle, which is the heart. It has the top chambers of the heart, which are called atria, and the atria are very thin-walled structures, whereas the bottom chambers of the heart are called the ventricles, and the left ventricle in particular is the main pumping chamber of the heart and really does the business of pumping all the blood around the body so that the body receives blood. And then we have skeletal muscle, which is what is affected in muscular dystrophies. But as I said, there's a great similarity between cardiac and skeletal muscle. And so that's why some of the genes are shared. And so if your genetic defect falls within a gene that is expressed in both the skeletal muscle and the heart, you can then have involvement of both of those tissues. And so it really does depend what your primary genetic defect is. And occasionally we see forms of muscular dystrophies that also can have some smooth muscle involvement, but to be fair, we're probably not as good at looking at that. And so sometimes I think we miss some of those clinical symptoms associated with smooth muscle involvement. So when we do a gene panel sequencing, we get sequencing done on a lot of genes. And this is just an example if you were to order with the company GeneDx and look at their neuromuscular diseases panel versus their cardiomyopathy gene panel, you actually see there's a significant overlap. And that's because, again, these are the genes that we know that can cause both skeletal and cardiac muscle. And that's what we'll talk about today. I touched on this very briefly, which is to say that sometimes when we're doing a genetic analysis, it's not always obvious that we're looking at the specific gene defects. It can be difficult to identify that sometimes. So when we look at gene changes between any two people, each of us has, millions and millions and millions of gene changes that are in our genomes. Most of that is quite benign and just the type of things and changes that make us each unique. But occasionally we see gene changes which are called pathogenic, and those are rare in the population and they cause disease. And that's the type of gene change or gene variant that can lead to muscular dystrophy. Vast majority of what we look at is benign, and those don't come back on our reports. But sometimes we see things that are called variants of unknown significance, which means the testing company identified something that's rare, but they don't have enough information to know if it's pathogenic. And this is, again, can be quite important in the limb-girdle dystrophies, where we do often see variants which are called variants of unknown significance. And sometimes your doctor can look at that information in the context of the details about your clinical history and maybe be able to interpret those a little bit better. And then occasionally, sometimes muscle biopsy information can help us interpret that. But I do know that people with limb-girdle, I have many limb-girdle patients, especially some of the recessive ones, where their two variants come back as being variants of unknown significance. So let's talk about different types of cardiomyopathy. Cardiomyopathy, the heart, as I mentioned, has two upper chambers, which are called the atria, and then two lower chambers, which are the right ventricle and the left ventricle. And the left ventricle is thicker and does more of the work of pumping the blood as it leaves out the aorta and goes to the rest of the body. The right ventricle, on the other hand, is more thin-walled and really plays the role of pumping the blood in through the respiratory system and providing blood supply to the lungs. And so it isn't facing as high pressures. And then the role of the two atria is to really fill both of the ventricles. In dilated cardiomyopathy, which is the most common form of cardiomyopathy that we see in the muscular dystrophies, typically we see the left ventricle and right ventricle become enlarged, although not always enlarged, and sometimes we just see the function reduced in people. And so a normal heart function, which we call the ejection fraction, about 55% of the blood is ejected from the heart with each beat. That's why it's referred to as an ejection fraction. And very often we'll look at people with muscular dystrophies and just see it declining a little bit, something like 50% or 45% or sometimes lower than that. But what's interesting is that the heart may not be that enlarged, particularly early in the disease, and the enlargement may come later in life. There are some forms of muscular dystrophies that can also be associated with hypertrophic, where the walls of the ventricle actually become more thick. And what happens there is that it becomes stiff and doesn't fill particularly well. And so the reduction in heart function really is more associated with having impaired filling properties of the heart, which then overall affect what we refer to as cardiac output. So this is a paper from a couple of years back, which did a very large look at almost 5,000 limb-girdle muscular dystrophy patients to begin to get a look at what is the distribution that we see in limb-girdle. And what you can see here is that a huge percentage of the patients were calpain. And we know that this is previously referred to as limb-girdle type 2A, and dysferlin, which was previously called type 2B. These are now called R forms because they are recessive. And these two forms, by and large, don't have dramatic involvement of the heart. We do see some patients that do develop some heart problems, but it's not the mainstay of, again, what we see with these. It's useful to check in with a cardiologist from time to time. And it's also important to recognize that if you have calpain or dysferlin, with age, you can just develop the normal things that happen to people's hearts with aging. And so again, it isn't to mean you can never have a heart problem, but we don't think of it as being dramatically affecting cardiomyopathy or rhythm. These ones, FKRP, Duchenne, of course, sarcoglycans, which are listed here, and several of these others, we do think of having especially important cardiac involvement. And so these are the types, if you carry these diagnoses, you want to get in earlier and make sure that you're seeing a cardiologist who's knowledgeable about muscular dystrophy. The other thing that can go wrong with the heart in limb-girdle dystrophies is you can have an increased risk of irregular heart rhythms or arrhythmias. And again, those are listed here, most important being LMNA. Desmond can have this, and then it's not on here, but filamin C can also do the same thing. And we're learning more about this all the time, where again, certain of these gene mutations really can have a very high arrhythmia risk. And we'll talk about this, especially in the context of LMNA or lamin. And so let's just go back and talk a little bit about cardiomyopathy versus heart failure. So cardiomyopathy is what we see when we look at your heart. We image your heart using echocardiography, or sometimes we do an MRI, and that's where we can actually see the heart. And when we see an abnormal appearance of the heart, that's referred to as cardiomyopathy. Heart failure, on the other hand, is a symptom. It is usually, in most people, manifest as that exercise intolerance or daily activity intolerance. So when people try to do things, they feel short of breath, when they exert themselves, or they just feel fatigued. Now, in somebody with neuromuscular disease who can't exercise because their muscles won't let them do that, or they can't exert themselves by going up 3 flights of stairs, many of the symptoms that we normally see in heart failure may be very difficult to detect. And instead, some of what we see as heart failure symptoms can really be things like fatigue or potentially swelling, especially in the lower extremities. So it's important to recognize that the symptoms of heart failure may look very different in somebody with neuromuscular disease. In people without neuromuscular disease, we recognize that there are many stages of heart failure, individuals who are at risk for it, individuals who are, again, at this cardiomyopathy stage where we may see something wrong, but they don't have any symptoms, individuals who then develop symptoms, and then people who develop a lot of symptoms, even though we're giving them all the medications that treat it. And the key part is that we have a lot of medications to treat cardiomyopathy and also to treat irregular heart rhythms. And so that may be different than what people are used to thinking about for their muscle disease, where we don't have as many things to treat. But in this case, we have a lot of medications, which we'll talk about in just a minute. So in Duchenne muscular dystrophy, there's been a pretty good organization around this to create what we call the care considerations. These were created more than a decade ago, and they've been updated, and they've also been optimized in terms of advising about older Duchenne patients and how to do that. But we don't really have a lot of that for limb-girdle muscular dystrophy, in part because the limb-girdle dystrophies are quite variable in when they present and what their progression is over a person's lifetime. But we can still learn a lot from these care considerations and apply some of these same principles. The main thing being looking how often do we look at the heart, the importance of having a team to manage both the pulmonary condition as well as the heart. And so I think that is what we can learn from this process. So in Duchenne muscular dystrophy, we know there's a pretty tight timeline. Most of the patients present around the age of, say, 5. Many are going off their feet by the age of 15. They're fully using the wheelchair full time. We know the cardiomyopathy really onsets between ages 10 and 15. And we use medications like ACE inhibitors and beta blockers and aldosterone antagonists to prevent and slow the progression of disease. We also treat these patients with steroids and provide pulmonary support. Becker muscular dystrophy, on the other hand, is the milder version of Duchenne dystrophy, which is incredibly variable depending how much that person is still making dystrophin. And I like to think of the LGMDs as being much more in the spectrum of what we see in Becker muscular dystrophy. Things can develop at many different stages in the lifetime. And so what it really means is that you have to be very proactive about your care and have a cardiologist and a team that really knows what they're looking for and how to manage you best. So what are some of the special considerations for managing the heart in muscular dystrophy? As I mentioned earlier, this general concept about exercise intolerance is something that just really doesn't apply if you're not able to do much exercise in the first place. So your doctor and you need to be much more vigilant about what your symptoms might be. And again, excessive fatigue or swelling in the ankles or bloating in the abdomen can sometimes be symptoms of having some heart failure. It doesn't necessarily mean there are many different things that can cause fatigue and swelling, but it just means to be on the lookout. We rely as cardiologists, especially in neuromuscular disease, we rely a lot more on what we call serum biomarkers. So we use one called BNP, which is brain natriuretic peptide. It can be measured in the blood. And I find this very useful in my patients that I just have started now routinely monitoring that and using it if it's elevated to be indicating that the person may be having some heart failure. It's not, or I should say it's pretty common in a lot of neuromuscular diseases that people actually have relatively low blood pressure, which we call hypotension. And that can sometimes limit how much we can use the medications that treat heart failure. Many of our medications that treat heart failure are in effect lowering blood pressure. And so if we lower it too far, that can actually make people dizzy sometimes or contribute to some of the fatigue that they can feel. So it's really important to stay on top of blood pressure and know what's happening. We measure things like kidney function a lot when we're treating heart failure. And the mainstay of how we measure kidney function is using something called serum creatinine. That's different than creatine kinase. So this is serum creatinine. And if your muscle mass is low because you have muscle disease, this number is always below the assay. So we can't follow your kidney function very well. Instead, we use something called serum cystatin C. That is something that your doctor can order, may not be so familiar with. Another test we can use is serum troponin. This is measuring for if you have injury to the heart. And we do measure that from time to time. I have now taken to routinely measuring this. And then the other piece of this is that liver function tests can be elevated from having muscle breakdown. And again, if they're treating your cholesterol, people may misunderstand this abnormality or what seems like an abnormality in liver function tests, but really is just reflecting what's happening in the muscle. So how do we treat limb-girdle muscular dystrophy, the cardiomyopathy associated with it? Well, in cardiology, we use something called guideline-directed medical therapy, or GDMT. You'll hear your doctor say sometimes. And how we approach this is the first line of medication is to use something called an ACE inhibitor or its cousin medication, which is called angiotensin receptor blockers. So either one of these, either an ACE inhibitor or an angiotensin receptor blocker, these are essentially in the same pathway. So we tend to use one or the other of those. Sometimes people get a little cough from an ACE inhibitor, and that's why we will use an angiotensin receptor blocker or an ARB instead. Beta blockers are medicines which are beta adrenergic blockers, meaning that they block the adrenaline system a little bit. And in doing so, they lower the heart rate and they lower blood pressure. And these are also protective for the heart and also protective a bit for irregular heart rhythms as well. So we'll use these very commonly. And many people who have cardiomyopathy absolutely should be on either one of these and then also the beta blocker. Then we also use medications called mineralocorticoid receptor antagonism. This is spironolactone or eplerenone are the main medicines that we use there. And then we now use medicines called neprilysin inhibitors. They go by ARNIs for short, and the main one of these that's in the marketplace is called Entresto. This can have a fairly powerful effect at lowering people's blood pressure. And if you're on Entresto, you come off your ACE inhibitor or angiotensin receptor blocker because this effectively replaces that. So it can be a little bit tricky to get on this and not lower your blood pressure. And then more recently, in the last 2 years, we've really started using medicines that we initially used to treat diabetes, but we found the heart. And these are called SGLT2I inhibitors, and the trade names for these are Jardiance or Farxiga. And again, we started using these in the treatment of diabetes. We now know they can be very effective also in people who have heart failure with reduced ejection fraction, like we see in our patients with muscular dystrophies. So just a word about cardiopulmonary involvement. So the heart and the lungs share the same space inside your chest. And the heart is in many ways surrounded by your lungs, and the underside of the heart is your diaphragm muscle, which helps you breathe as well. As we know in muscular dystrophy, your breathing can be really affected. You want to make sure you have a pulmonologist who's really knowledgeable about treating people with muscular dystrophy. Many of you or many of my patients are on respiratory support at night in particular, and that really, really helps the heart function, helps the right ventricle function, and can relieve excessive high blood pressure in the pulmonary arteries. So it's really critical to make sure that your respiratory needs are being met and that you're being monitored regularly for this. I want to start by talking about the timing of when to go on medications for your heart. So we know with many forms of genetic muscular dystrophies that a person is extremely likely to develop cardiomyopathy and at risk for heart failure over time. And we know that very well in the setting of Duchenne muscular dystrophy. And I point out this paper, which is now over 15 years old, because it was one of the first examples where we said, let's not wait for the heart to get bad. Let's actually start the medications early, in this case, an ACE inhibitor called perindopril, and let's start this medicine before the heart gets bad. Overall, these medications are extremely well tolerated, and so generally it's reasonable to think about starting them early. And so this was started in children before their hearts got bad, and then they followed them for 3 years and saw how they were doing. And then after 3 years, everybody got placed on ACE inhibitor perindopril. And so at the end of 3 years of treatment, everybody still had pretty good ejection fraction, up over 45%. Everybody started out at over 45%. After 3 years, you see a couple of the patients drop just a little below 45%. But at the end of 5 years of treatment, where several of, a bunch of these patients all got randomized to receive early treatment, you see that those who were receiving the early treatment generally maintained their function much better, whereas those who got the delayed treatment and didn't start it on ACE inhibitor until 3 years later, many more of them had dropped off their function down below 35%. So this becomes the argument for treating early and not waiting for the heart to get bad. And so in my practice, we have conversations about when's the right time to start that. That's a very personal decision for you and your doctor to make together. But the point is, don't wait for the heart to get bad. At the first signs of anything looking abnormal, or even before that, it's reasonable to start on cardiac medication. This was just a long-term follow-up from that study where they also showed that the people who got treated with the perindopril early lived longer and did better. So how do we monitor the heart in neuromuscular disease? I told you at the beginning, you have to know your gene. We recommend heart imaging on a regular basis, so usually an echocardiogram every 1 to 3 years, an EKG, which is just where we monitor the heart for 6 seconds. That's usually done in the doctor's office. That's every 1 to 3 years. Holter monitor is where we monitor the rhythm of the heart, and that can now be done for 7 to 14 days using these patch monitors, which I'll show you in a second. That's every 1 to 3 years, depending on whether there are symptoms present or what the baseline showed. And then I like to do MRIs every 3 to 5 years, but that might be more frequent depending on the setting where you are. For your respiratory care, you want to be doing spirometry, measuring your breathing function in sitting and laying position, overnight oximetry, and just making sure you're on top of this and using respiratory support at night if you need it. And then, of course, the blood tests we talked about, looking for those biomarkers. So just a little bit about echocardiography. Echocardiography is the easiest heart imaging to get because it's done many different places. And echocardiography relies on ultrasound. Ultrasound imaging of the heart usually requires the person to be on a table, although I have to say our imagers are exceptionally good and do lots of imaging in the presence of patients who are in their wheelchairs, because sometimes I know it can be very difficult to get out of your chair and onto a table. And so especially if you have a chair that tilts back, we can do really good images. And we basically look at the heart in 3 different views. We do what's called the long axis view, where we get a real nice look at the left ventricle. We do what's called the short axis view, where we see, again, the left ventricle in what we call the donut view here. And then we get a little view of the right ventricle. And then we do what's called the 4-chamber view, where we see all 4 chambers of the heart. And the echoes actually go all in these same views. And what we don't see particularly well is the right ventricle. The right ventricle is a little bit hard to see. So this is just an example of a 4-chamber view. Left and right are reversed in the way we do this, but this is the left ventricle. You see that the walls are thicker, the right ventricle not as well seen, and the right atrium and the left atrium, and then the valves in between. And that's how we get a pretty good look at what the heart looks like. It is also very dependent on chest wall. And so if you have a very abnormal chest wall for whatever reason, we may not be able to get very good images. And somebody who has a lot of scoliosis and kyphosis, bending of the spine, may make it hard for people to see that. We also use cardiac MRI. This is a big tube that you have to get on the table. So absolutely, this can't be done in your chair. You have to get onto the table and it slides in, and we take images. For some of my patients, this is hard to do because getting on the table can be difficult. Even with support, it can be difficult for people to lay flat for the study. And you have to be able to hold still for the timing of the study, and you can't have any metal in your body. We also inject people with a contrast called gadolinium, which gives us a better view of the heart. And we do get some better information from this, particularly the quality of the tissue of the heart. We can see things like if there's scar present on the heart, and we can certainly get a much better view of the right ventricle. And this is an example of that 4-chamber view here, where again, we see a heart that has a lot of this white material is actually scarring on the heart. And that's something we just can't see with echo. And so we do get some better pictures when we do this in the MRI. I just wanted to throw in a word about stress testing. Some of you, as you age, your doctor may talk to you about stress testing to try to look for more common heart problems like blockages in the arteries. Stress testing involves running on a treadmill, and people with muscular dystrophy can't run on a treadmill. And so if you have to have a stress test, just to mention, it can be done using injectable material that makes your heart beat hard and fast and mimic exercise. And then we can take images of the heart, either an echo or a nuclear study, to try to get an idea of what the heart looks like under stress. And so just to be aware that that can be done for people in who have neuromuscular disease, but usually requires what we call a chemical version of exercise. So now I just want to switch and talk for just a couple minutes about the electrical system of the heart, because I also said that the electrical system can go wrong in some of these disorders. So the heart initiates its beat up here in the top, which is called the sinus node. And then the electricity travels down here to what's called the AV node between the atria and the ventricles. And then it sends its electricity down through the ventricles. And this is how the heart coordinates its beating. We can see this electricity on the heart by just looking at the EKG. So we first see this little bump here, which reflects this is called the P wave. And that's the atrial activity. And then we see this big up and down, which is the Q, R, and S, and this is just named for letters of the alphabet. That big depolarization, as we call it, is the electrical activity of the ventricle. And then we see the T wave, which is the heart sort of resetting itself and getting ready to do its next beat. And so just doing an EKG in the doctor's office gives us a lot of information about how the electricity is traveling through the heart. So when we do an EKG in the doctor's office, they put what are called the leads in particular places on your body, and it gives us the electricity going through the heart, but it measures this only for about a total of 6 seconds. So it doesn't give us a very long look at what's happening in the heart. It's just a 6-second snapshot of what's happening. When we want to know what's happening in the heart for much longer periods of time, we do what's called a Holter monitor. In the old days, this used to involve wearing a fairly large box that was attached to you and these leads, and you would wear this for 1 or 2 days. It was fairly annoying because these leads would fall off and you couldn't shower with them. And then these days, what we do much more is what's called a Zio patch. This is a much smaller device, and it just sticks right on the skin, and it has this little sort of bubble area in the middle. And you can wear these for 1 to 14 days. You can take a shower with them, and we get a lot more information off these. And so we most often use these Zio patches. There are also what's known as event monitors that you can wear for 30 days. And there you can trigger it if you're feeling an irregular heartbeat, or it can trigger recording when it senses you're having an irregular heartbeat. We also now use a lot more devices that people wear for themselves. And so probably the big one that most people use now is many people have a smartwatch, which is capable of EKG monitoring. These are really terrific for documenting atrial fibrillation, which we know can be increased in some of these disorders. And you just wear the watch, you get these pretty amazing looking tracings, and you can capture that on your phone and even send it to your doctor. Another device is one that goes directly on your phone. It has these 2 little metal pads that fit on the back of your phone, and you put your 2 fingers on both pads, and it also can give you a tracing, but you have to be able to, if you feel the irregular heartbeat, you have to be able to put your fingers in this position. The advantage of the watch is that it's just sitting right there on your wrist, and it really can capture information. Heart rate monitors are also really useful. They can be worn on your wrist, they can be worn on your chest, and they can just tell you what your heart rate is doing, how fast is your heart going. And so we get all sorts of great information now from this. And over time, I think this is just going to be really what we do for almost everybody. If we detect irregular heart rhythms, either the heart going too slow or too fast, we recommend insertion of a device. And so a pacemaker is the device that goes inside that paces your heart if it's going too slow. A defibrillator is a device that sits inside the system, inside your body, and it detects if your heart is going too fast, and it will deliver a small, it will either deliver pacing or a small shock to actually reset the heart if it's going too fast. Now, very often what we in fact use is a combined device that's both a pacemaker and a defibrillator, and that's not unusual to have. This is an example of a defibrillator in action in a muscular dystrophy patient. So what we see is the heart's just kind of beating along normally. It all of a sudden starts going into this crazy rhythm, which we call ventricular tachycardia. The device begins to sense that. Sorry, it's jumping around a little bit. It senses it and then delivers a small shock and then just resets the heart back to its normal rhythm. And when it does this, it actually delivers a very small shock, small electrical shock, because it's right inside next to the heart. So it doesn't need to deliver a very large amount of electricity in doing this. This is an example in a person with an LMNA mutation. So I said this can cause muscular dystrophy. And again, where you can see that we can see long pauses. So this is a heart that paused for 4.7 seconds and didn't beat. And so this person ended up getting a pacemaker defibrillator. And in fact, more recently just started having problems with ventricular tachycardia, and his device has been working to basically save his life. And so that's why it's really important to know what your gene change is. So I mentioned that lamin, LMNA, it encodes a protein called lamin AC, which is here. We know that that's a gene that has a special high risk for having irregular heart rhythms that can be one of the first things that people present with. And we know that if you're male and you have a lamin mutation, or your heart function is down, or you have a particularly bad mutation that is greatly disrupting the lamin, that those carry even higher risks associated with them. I want to also mention this gene called FLIN-C, so filamin C, because this can also cause muscular dystrophies or myofibrillar myopathy sometimes. We also now recognize FLIN-C as having an especially high risk of having irregular heart rhythms with it as well. And so that's another one where you want to make sure you're doing extra heart monitoring for this purpose. Titin, many people, so what hasn't been captured well in a lot of our prior studies is we now know titin, which is an enormous gene in our body, the largest gene, and it encodes a very, very large protein called titin. And about 2 to 3% of the population actually has a disruption in titin. That can lead to both heart muscle disease and muscle disease. And because this is so common in the population, it's now being increasingly recognized for both causing dilated cardiomyopathy and, again, probably a little bit of skeletal muscle weakness as well. We now know so much about titin that we can ask the question in a reverse way, which is to say, like, if we just look at a whole bunch of people with titin, what kinds of problems do they have? What you really see coming up is that they can have cardiomyopathies, they can have ventricular tachycardia, reduced heart function, atrial fibrillation. And so again, this has now become a really important gene for making sure that you're managing both irregular heart rhythm as well as cardiomyopathy. So when people have tried all the medicines that are out there and things aren't working, we do have some more advanced options. We have pacing that can pace both ventricles, and this is called cardiac resynchronization therapy, or CRT. Sometimes people need to be on blood thinners, especially if they've had AFib. And again, if you have a lamin mutation, anticoagulation is something we typically do. Sometimes we use infusion therapies, things that we infuse into the body to make the heart stronger. In left ventricular assist devices, or even transplant can be considered. And we've gotten quite a lot of experience now with left ventricular assist devices, and that's sort of a heart pump option that can be placed in a person if the heart function gets really bad. But just on a last note, I want to leave you with this from the American Heart Association, which is, remember, many people with muscle disease live a pretty long life. And so even normal things that can happen to the heart can happen to people with muscular dystrophy. And so the American Heart Association frames this around Life Simple 7, which is to make sure you're eating healthy and watching your weight, which can be really hard to do in neuromuscular disease because exercise is really hard to do. Of course, don't smoke, but make sure you're on top of your blood pressure as you age. Just like anybody else, you can get high blood pressure, you can get high cholesterol, and you can get diabetes. And so all of these things need to be managed. And then I like to add number 8 to life's simple 7, which is to make sure you've gotten vaccinated for COVID and also for flu, as we're looking at flu season coming up in the next couple of months. So with that, I'm just gonna, again, high level conclusions. You have to know your LGMD genetic subtype. That is the most important thing for predicting whether your heart needs to be followed by a cardiologist. The heart can be treated early. You want to manage blood pressure and cholesterol and don't smoke. Certain genes that can cause LGMDs have a very high arrhythmia risk, lamin, desmin, filament C, and a few others, and should be managed accordingly with a lot more monitoring. These days, we sometimes put what are called loop recorders into people to really stay on top of that monitoring. Your cardiologist should care what type of muscular dystrophy you have, and your cardiologist should work with your pulmonary and neurology team. And so with that, I will thank all of you, and hopefully you are all well.
Thank you to all of the attendees for participating in this event. As individuals affected by a rare disease, spreading awareness and working together to develop treatments is so important.
Don't forget that the 7th annual LGMD Awareness Day will be celebrated worldwide on September 30th. I invite you to join us as we advocate, educate, and celebrate. By increasing awareness of and advocating for individuals living with limb-girdle muscular dystrophy, we hope to assist in advancing the diagnosis, care, and treatment around the world. And remember, together we are stronger.
Thank you so much for attending this year's conference. This conference is really dedicated to all those who struggle daily to live their best life with LGMD. As individuals with the disease, we are proud that we have organized the conference. Many people would never know the struggles we each face and the hard work we put into this conference to bring you the very best we have to offer. Believe there is hope for a cure. This is our conference theme, and it will be our theme until we see treatments for every subtype of LGMD. I want to take a moment to remind you to join the LGMD Patient Network. We are a patient-led organization, and we are dedicated to helping those living with LGMD. The Speak Foundation has the only LGMD registry that is patient-led for all subtypes of limb-girdle. If you want to join our LGMD Patient Network, go to our website at thespeakfoundation.com. Thank you for joining us for this year's conference, and we'll see you next time.